apologies from Richard May, and are welcoming Victoria Wallace as the Deputy Trust Board Secretary. This is your first meeting, Victoria. I'm sure you'll do fine. We're also welcoming Karen Spellman from NGH, who will be presenting Item 7 on the Integrated Care System. And we are welcoming John Evans to his first board meeting since joining as Group Director of Finance. And I think we're also welcoming Teresa Batang for her first board meeting as Group Director of Communications. I can't see anything else there that I should be mentioning at this particular point, although you never know. Are there any other apologies or declarations of interest? No, good, excellent. We're going straight into the topic Equality and Diversity and Inclusion, EDI for short, and including reflections on the reverse mentoring scheme. Just in case anybody wonders, my reverse mentor was on the Northampton board yesterday. So I was part of the scheme and gained a huge amount from it, but she's not on this particular call. At least I don't think she is. Anyway, we've got 45 minutes for this, about half an hour for presentations and then about 15 minutes for conversation, which was pretty robust conversation yesterday, pretty good engagement right across the board yesterday. So, Mark,
Thank you very much, Alan. So I'm really pleased to be sharing this item at our board meeting this morning to demonstrate our progress on the ED&I agenda as it stands at the moment and our future direction. And we want to share that with the board. But before I do, I'd like to welcome and thank colleagues for supporting me in this presentation. So as we go through the presentation, we'll have Carol Werner, who's our Head of Equality, Diversity and Inclusion, who will present where we are with our EDI progress to date and where we wish to go in the future, and indeed our objectives over the next 12 months. We then have Faisal Ryan, who's joined us to discuss our REACH network and again, progress on where we have come to with our REACH network, and indeed where we would like to go in the next 12 months and actions that we'd like to undertake. We also have Sri Jafnair with us, who, should Faisal be called off an emergency, is ready to take over should that be required. And then we also have Andy, who we all know, who is the executive lead for the REACH network, who's going to discuss or remind us what we signed up to as a board just over a year ago, our progress to date, which includes the reverse mentoring program, and indeed our future actions and desires for the next 12 months. We also have a number of other colleagues, as you rightly pointed out, Alan, from our reverse mentoring program who have joined us, and they all star in our videos. So you are all very welcome. Olu, Rita, Rudu, Kelechi, all very welcome today in terms of sharing the experience of being at a board meeting and also to be part of our debate. The presentation, as I say, has four main themes: our progress, our REACH network progress, and our board progress. And then finally, I'll be picking up the baton in relation to our ED&I strategy across the group. So what is it we now plan to do across the group, or continue to do across the group in both hospitals, acknowledging that both hospitals are in slightly different places or slightly different starting points on this particular journey. We still have a lot of work to do, and it was a fundamental key item in the people plan that we approved in March that we would come back to the board with our group ED&I strategy, which I have to say has not just been created locally and across the group, but also has had involvement in relation to system and regional colleagues' aims and objectives too. So we will then, as Alan rightly said, after the presentation, have plenty of time for comments, discussion, debate, etc. And so I will hand over seamlessly to Carol so we can create as much time as possible for the presentation. Over to you, Carol.
Good morning, everyone. I'm just going to start off with giving an overview pertaining to the NHS staff survey in 2020. If we can have the next slide, please. So our response rate was 58%, and this was significant to the organization because there was an increase of 7%. And pertaining to EDI, we saw an increase in the responses to EDI questions in comparison to previous years. And in comparison to 2019, we had a 23% increase pertaining to EDI questions. And when we looked going back to 2016, there was a 122% increase in relation to the responses to those EDI questions. when we've looked at the theme results overview, we achieved as an organization 9.0%, and the average was 9.1, and the best organization was 9.5. So we've taken action from that, and we want to improve our overview based on theme results. If we can go on to the next slide, please. This is an overview analysis of our headcount within KGH based on 5,995. This is including bank. We've got a breakdown of 77% of our workforce being female, and this has led into ensuring that we've got safe spaces, which is gender. I beg your pardon? Oh. We've got 77% of female within the workforce, and this has, we've then worked as an organization to ensuring that we now have a gender safe space for EDI. We've got a breakdown of sexual orientation, which is showing a clear outline, but I would like to flag on the 33.94%, which is the not stated and other. This is a work in hand that we're working as an organization to try and address where people have not declared their sexual orientation, so that we are helping that understanding of the importance of that information to enable the organization to support them. If we can go on to the next slide. Pertaining to disability, as you can see, we also have a 35.40%, which has not declared. And based on what we've learned in the last year, due to COVID, we had more during the risk assessments. It helped highlight that we've got more staff that are within the disability umbrella that have not declared. So we will be working, and we continue working to helping our workforce understand the importance of declaring that information to enable us to support them, especially when we have pandemics within the nation or the world. Our disability rate is at 2.50%, that is declared. And based on ethnicity, we've got a clear big breakdown of ethnicity based on BAME and white. The not stated is at 3.39, and we continue working to decrease that as well. Next slide, please. Last year, when we came to the board, we had a strategy plan as outlined by Mark, but we had 4 key areas that we wanted to address. But within those 4 key areas, we had different deliverables that we wanted to be able to start progressing and achieving. So under attraction, recruitment, and selection, we have in the last year been working on having our inclusive recruitment champions within panels. We've piloted the champions in some of the appointments for senior leadership within group and in various between KGH and NGH as well. And we now have 18 trained inclusive recruitment champions within KGH and NGH. Why have we put that word trained? It's because as an organization, we wanted to take an approach of ensuring that people have a clear understanding coming from the various protected characteristics, why it's important for the organization to have champions within the recruitment processes and why we are doing it. But to support our managers, we also have created training for recruitment, inclusive recruitment awareness, so that managers also understand why we are embedding champions within the processes and what we are trying to achieve. Our champions feed back to EDI team, and we are working closely with the recruitment lead so that if any issues are raised, we're able to address them and support the agenda in delivering a successful recruitment process within the organization. And then another second key area we wanted to work on with different deliverables, the few of the deliverables was utilizing data for positive action. So we had the EDI training for staff. So in all our EDI training that we are doing for managers and staff, we are helping raise the awareness of what raise and days data and staff survey relates to and how they all interconnect so that they understand the importance of where all the analysis comes from. We are also the EDI reports that we've run within the organization have also helped us to be able to achieve an engagement in ensuring staff got, they were engaging in the COVID-19 vaccine. And the current reports have shown that we are above average for COVID-19 vaccine uptake, and that's a positive for our organization regionally. And we also have the Why Declare campaign, which we've been running, and this is to address those unknown elements within the ESR reports information for our workforce so that we ensure we get that information at hand within the system. So we are running a campaign, and since December, we have seen the reduction of unknowns, and we'll continue working on that information. If we can go on to the next slide. The next action was ensuring that we continue creating safe space. I think regionally and nationally, we were required to ensure that we're supporting our BAME colleagues within the organization. So the organization, instead of us only creating a safe space for BAME staff, we identified as an organization that there were more spaces we needed to create because there were other issues that were coming through. So we've ended up creating 6 active networks, which are growing. 4 were relaunches, they already existed, so we're just relaunching them. And 2 were new. The new were the Gender Equality EDI network and the Young Peers Support EDI network to support all our programs relating to apprenticeships. And then we now have 90% of coaches trained as Freedom to Speak Up champions, of which 80% are from a BAME background. We now have 2 BAME staff governors as well within the organization. And then when we go on to going on to supporting our workforce, we needed to come up with what are we going to do pertaining to training and getting that understanding, because it's easy to perceive that everyone understands what EDI is about. Some people believe it's only race, and some people forget it's about everybody within the organization. So we came up with training material that we've started rolling out within the organization. So the EDI team is now, we've got a team that's working and training is ongoing. We've got talking about the uncomfortable training. If anyone is interested, they should join. It's talking about uncomfortable issues, and not only issues, but words that on a day-to-day basis, if they're thrown at you, it might be taken back and it might make you uncomfortable. They also make me uncomfortable. So we are starting this from July this year. And then we've got Building Cultural Bridges training program, which has already commenced within the organization. And we're also supporting NGH in delivering this program. We've got the EDI presentation now, which is available for all new starters, as well as all our overseas staff. We've also been supported by the OMG and IMC in having protected time for EDI coaches. And I think this is, shows how dedicated the organization is pertaining to ensuring there is that support given to all the EDI networks and our inclusivity journey. We've not yet agreed the effective start date, but everything is in place pertaining a protected time for EDI coaches and chairs. If we can proceed to the next slide, please. This is just a show-off slide of the first ever cohort for the Building Cultural Bridges training that we did at KGH. And as you can see, some of the outlines, you know, where we perceive people have an understanding of each other and where some of these issues coming from. I think the first step the organization has taken of educating and embedding understanding is so important in view that we're a diverse organization with multiple different cultures within there. So we had some people have now come to understand the importance of equity and understanding that equality is not the only journey. So KGH is taking an equity approach because we are now doing these trainings within our organization. If we can go on to the next slide, please. In supporting workforce, you know, it's not only working within our organization, we've been able to ensure regionally, we now have a BAME delivery group representative within KGH. One of the heads is one of the representatives for our trust. And we've also been supporting regionally where other trusts, they liked the approach we've taken and the framework we've used pertaining to setting up EDI networks. So we've been sharing our experience, our journey of setting up our EDI networks and EDI strategies within the region and also nationally. And we had one of, well, we've been published in many publicity forums, but the HSJ and the NHS providers was one we wanted to share with everyone, with Andy Carlo helping us to shine the journey of inclusivity within the organization. If we can go on to the next slide. This is just all the 6 EDI networks that KGH now have, which are fully functioning with amazing board sponsors that are now engaged. Before we just had the exec teams, but now it's been extended following on from what we had agreed in various meetings where the non-execs were going to also be part of being sponsors. So we now have for some EDI networks, exec sponsors and non-exec sponsors. So this is our full colors of EDI networks showing diversity as well. If we can go on to the next slides, please. Now, what do we want to achieve in the next 12 months? As an organization, we're going to continue. We want to approve and continue delivering the EDI strategy for the group, because now we are a group trust. We want to continue supporting our EDI networks to grow so that all our staff have that safe space where they can come and share their needs and their needs are able to be addressed. We have training and networking programs being developed, and some have already been developed to support our EDI network coaches. We will be launching the United Allies program. Some might have heard nationally as White Allies program. We've gone to the approach of using United Allies as an organization because to us that was more inclusive. It wasn't focusing on color or race. So United Allies, because we want to be united in our vision for inclusivity for our organization. And we're going to continue developing the role model stories across the trust, from staff groups, from protected groups. And this is, when we say protected groups, it really is everybody within the organization, but we also fully focus on those from underrepresented groups within the protected groups. We're going to be embedding a cultural change and understanding through training programs, because that's proving successful and it's a positive way forward. We want to achieve a 5% of our staff by next year having attended building cultural bridges. 80% of recruiting managers, we want them to have had the inclusive recruitment champion awareness for managers. We want to have talking about the uncomfortable 5% of our staff. And we want to have by next year 150 trained champions for inclusive recruitment, so that we are able to better support the recruitment processes within the organization. I will now hand over to Faisal, who's going to share their journey pertaining to REACH. REACH was formerly BAME. Thank you very much.
No, sorry. Thank you. Good morning, everyone. It's a bit nervous for me to start with, because the number of achievements which I think we can enlist, it's really quite a lot. But to highlight a few, I really want to say that the experience in last few years, we know that it's when it is an inclusive place, everyone wins. And keeping the team motivated and bringing this diversity into a highly creative and high-performing teams, I think that's what we have achieved in last 2 years, and especially through the COVID, the experience what we had. The most highlight, the biggest highlight I would say is the vaccination and how they have achieved above the average of what Midlands have achieved. So we are much above the average, and we will try to continue with that. So I will start with a few highlights now. So one is our KGH and NGH, the EDI REACH network, how we collaborated. And then, sorry, before REACH, we were like BAME network. And from there, how did we achieve the name REACH? And we agreed on a common name, and we started off with that. Then we had at least increased the membership to, I think, more than 300 now. And we had reverse mentoring mentors, which are all BAME staff. And I think 80 BAME staff are awaiting to be trained. And there are still things happening. But the first cohort, we had more than 75% BAME background team who had inclusive recruitment champions were made from this group. Then we also had a World Skills UK Award, which is in a partnership with Coca-Cola, and we were nominated for that. Then we also had, or we are going to have a welcome directory for the overseas candidates, which will be published shortly, maybe in August. But these are, again, for me to say the achievements personally also, like when I went for this inclusive recruitment training, and the personal experience was brilliant, and the support I get from the mentors, and it was brilliant, really. I can't really explain it in words, but it was brilliant. And I think that was the same feeling as a team we all had. And I would like to continue with this, and in fact, whatever we can finish it and get the same confidence in the team around, that'll be the achievement for the next few years to get that. Anyway, if we can move to the next slide, please. Sorry. So what we want to achieve in the next 12 months is that how we can gain the confidence in the rest of the team, and how, as it's not just ED. When you say EDI, it's a vast thing. It's not just about BAME or disability team or youth peers. They have so many pillars, and we want to achieve how we can really gain the confidence in each and every member and how we can really propagate this. So we are working, we would like to work with HR to ensure that all staff from rich background, we can give the information, whether it is one-to-one or through digitally, how we can really tell them how we can support them, and in case if there is any challenging situations. The next important thing is how we can make the policies, how we can report on promotions, development, how we can achieve this for every EDI network members. Regarding anti-racism policy, we would, in next 12 months, we would like to really refine the anti-racism policy and procedure, and how the organization is going to achieve this. This is what we are going to see in the next 12 months. And also the reverse mentoring program, which I know that most of my colleagues will say this was a great success, and how we can encourage other staff members to achieve the same. And we are trying to get more people into reverse mentoring program. And we will have more interview mentors within the EDI network to support with applications and interviews. Because personally, when you go across the wards and things, I've come across our own staff members, asking, oh, I've been shortlisted, how we can get the support. And now we have EDI members, we have the BAME network, and we go, sometimes it's one-to-one. And now we are creating a more structured framework where they can really achieve this kind of training. And I'm sure Carol is working really hard, and the support I get from Andy Callow as the mentor, I think it is immense, and I hope we will continue with this, and we will keep you updated. On that note, I would like to hand over to Andy, if I'm right.
That's right. Thanks, Faisal. Can we have the next slide, please? Okay, colleagues, I'm going to dash through this to give time, because we're actually, the main thing here is to have conversations with our colleagues who have joined us. And so this is what we agreed that we would do last time, as you'll see, broadly on track in many areas. And there's a hint there for Ned colleagues to join the groups. You'll see there's 4 that are missing their sponsor. But really today, I don't want to focus so much around that. I want to talk mostly about the reverse mentoring. So if we can have the next slide, please. And I'll just touch upon this, and you'll have heard through various people, we've had great feedback from it, but it's only the start. Those conversations need to turn into action and into behavior change within our organization. And it's with my great pleasure that I'm going to introduce the video that many of us on this call have taken part in. Thank you.
My name's Kelechi Adieze. I'm a Deputy Assistant A&E at Kettering General Hospital.
I'm Andy Callow. I'm the Group Chief Digital Information Officer at Kettering and Northampton. I'm also the Executive Sponsor for the REACH networks at both hospitals.
Hi, I'm Simon Weldon. I'm the Group Chief Executive for the University Hospitals of Northamptonshire.
Hi, my name is Rita Onibe, currently working with the practice development team in the recruitment of international nurses from all over the continent.
My name is Oluwase Yajiboluwa. I'm a registered nurse working in D&C ward in Kettering General Hospital. I joined Kettering General Hospital in November 2019 as an international return to practice nurse.
And I'm Mark Smith. I'm the Chief People Officer for Northampton and Kettering Hospital.
So one of the things that I learned that made me feel really sad was the way that having a visa drives behaviour. That made me feel really uncomfortable that people would not speak out about injustice and complain about prejudice
for fear of jeopardising that visa situation, which is clearly not the case. And I think we need to do more in the organisation to help communicate that the two aren't related.
What I have gotten from the reverse mentoring program is learning from Simon that the trust is really interested in getting to know our cultural differences and finding ways to bridge the gaps that exist due to these cultural differences. And it has also given me the opportunity to talk about sensitive topics that I have left unsaid due to the fact that I had not been given a safe space as I have been given now to talk about those things.
So one of the earliest things I learned from Rita was how body language and how behaviours can be interpreted entirely differently, and it really made me think about not judging people just on the first reaction that they gave, and also the immense amount of bravery that people have to have. Rita came to this country by herself, had to start out all over again almost. And we take for granted, we who live in this country and come to it with all the kind of knowledge that was just enormously, I remember feeling in awe of how enormously hard that was to kind of go to somewhere you don't know and completely start over.
And for me, the programme has been hugely exciting and hugely eye-opening in terms of the international nurses programme, but also the experience of our international nurses. I hold a position where I may be able to influence change in that particular period, in that particular area, so we don't repeat any mistakes that we may have made beforehand, and we make sure it's the best and most positive experience it can be.
I'll be looking for Rudo to be able to really challenge me on how I'm making decisions, how I'm including people in the organisation and the engagement, and the way that I communicate with the organisation. So it's really about challenge, being open with each other, having that understanding of each other and supporting.
For me, I took it as a challenge. In a new leadership role as a Band 8, leading the therapist team as a clinical specialist as well as a team lead. So having Debbie under my wing or me under her wing, it just gives me a different perspective on her leadership style and what I can learn from her. But above all, it's just forming that close relationship where we can come up with ideas together and I can help to influence maybe some of the decisions.
What I would suggest moving forward from now is the continuation of the reverse mentoring program and giving everyone in the trust the opportunity to be a part of the reverse mentoring program, and this way we can bridge the existing gaps in the trust. Thank you.
Right, so the two things I would like the board to take on board is regular meetings with the people that have been reverse mentored or even with the mentees themselves, just to think about these things, talk about these things at the board level and take actions. And the second one would be making the building cultural bridges a mandatory training for all staff so that everybody's on board with the training and they know what it's all about and they can relate better at the workplace.
So I just wanted to use this opportunity to encourage my colleague, international nurses, to come on board the program. I believe whatever they are able to bring on board, it will give more insights to the leaders of Kettering General Hospital and to be able to make a more, decision making as regards to international nurses. Thank you.
So I think the video speaks for itself, and I think one of the most powerful comments there from Rudo was around taking us under their wing, and I think the mentors have really done that in the last 12 months, and we look forward to that in the future. If we go on to sort of thinking about what we're going to do in the next 12 months, and I'm not going to go into these details, but I think what I'd like to call on us as a board is to be really ambitious and really sort of push this agenda forward. And many of you know that the White Fragility book has been really impactful on me this year. And I just want to read a quote from it to sort of challenge us. And Robin DiAngelo, she's talking about society and our organisational structures. And she says, the default of the current system is the reproduction of racial inequality, and it does so with efficiency. To continue reproducing racial inequality, the system only needs white people to be really nice and carry on and be friendly across race. But niceness is not courageous. Niceness will not get racism on the table and will not keep it on the table when everyone wants it off. So we have some actions there that we're committing to. And I will finish by giving a challenge to all of us on the board, is to say, what will we do this year to keep in that uncomfortable zone and keep racism on the table? Thank you. Over to Mark.
Thank you, Andy. And so courageousness, as Andy said, there is one of our values, our new values across the group, and I think it's really important that we take that forward. The other one is accountability, is another one of our values. And if I could take the next slide, please, Kieran. It's talking now around our ED&I strategy and what we aim to achieve. And this is how we can keep ourselves accountable. We set out a strategy. This is what we say we are going to do. And then we can measure ourselves. Are we delivering this? Now, the strategy was born and has been built, as you'd imagine, from EDS2, the Equality Act of 2010, and various other national, regional, and local policies and guidance, including some of our own recent strategies. And if I can take the next slide, please. It has 5 particular goals. They're articulated within our papers today, and hopefully everybody has an opportunity to read the strategy. But as you saw from Carol's presentation earlier, there are specific measurements that we're going to put in place in regards to measuring ourselves against that strategy. And one of those is the Building Cultural Bridges programme. I said in Northampton yesterday, we do have a target, as Carol's articulated, of 5% of colleagues across the group. So that's 500 people being educated in this particular way. But I wonder if we need to consider how we and where we can place that training. Now, that's not to say we do 5% and we're done. Clearly, there'll be the next target that comes along once one's been achieved. But I would encourage everybody to have read the strategy and looking for your endorsement and approval of that strategy today. But as Andy and colleagues have rightly said, it's now time for discussion and debate about this particular item, including the stars of our show and the reverse mentors and their fantastic videos that we've just been able to see. Thank you very much. Over to you, Alan.
Thank you, Mark. Very impressive stuff, everybody. Thank you all for coming along. I am opening it up for a conversation now from anybody who's been part or not been part of the process and what you thought about all of that work which has been going on. And I'm not seeing any. Right, Trevor, please, and then Alice.
Thank you, everybody, for the presentation. It was, very, very helpful and sort of aligning the thoughts, and particularly Andy, your last thing about the keeping the courageous on the table. The whole thing on the table. I wasn't clear in terms of reverse mentoring. How many people do we actually have on the scheme at the moment? And whilst I'm sure we want more, what is it that we see as our target for having people in the reverse mentoring programme?
Shall I come in to answer that, if that's okay? So we currently have 6 colleagues, Trevor, going through the reverse mentoring programme and being mentored by colleagues from our BAME community. Ideally, we'd like to be at 100, if I'm honest. So I think it's a case now where we have a number of people that we're able to showcase the positivity around the programme and what the programme can bring to both parties in that relationship. Although I have to say, I know Olu's on the call, I think I always apologise. It feels I'm always taking more from that relationship than she gets from me. But there is, I think it would be something that we would do consistently, not just at the board level, but also other senior leadership levels in and around the organisation. I think we've demonstrated the impact the programme can have. We've demonstrated the benefits that it can have. And I think it's, let's roll it out to as wide and as many people as possible. That's my aim. I haven't set a percentage number against that, but as many people as possible. What we don't want is to force people in the relationship. It's really important that it needs to be something that somebody's willing to undertake on both sides of the aisle, as it were, because you can't force people to have this type of relationship. The sort of things that we discuss in our conversations, they are very personal and very and very open and honest, and I don't think you can build that if you force people to work together. So I think it's as many people as possible is the answer, and as soon as possible, but in a every side willing way, as opposed to a forced relationship.
Okay, thanks. Alice and then Janet, please.
Thank you, and thank you everyone for that presentation. I just wanted to bring back to the point that I think Carol flagged up around the relatively high percentage, 30-something%, that haven't declared a sexual orientation. And I just wondered if we had any insight as to why that was, because that initially was a concern to me, that the initial step has to be presumably that we have a culture where people are happy to do that, and then we can take steps to ensure that we're including people. So just wonder whether we had any reflections or data on that as yet.
Let's collect a few of these before you reply. And Janet?
Thank you. I popped in the chat a specific area around research, and I'm thinking that as the organisation moves and is a university teaching hospital group, we really need to think about how fantastic this work is, how it's a model that others could use, but how bringing in the component of research to really back up the evidence, provide further assurance, I think would be a really good thing and a great opportunity to open up for potentially a research fellow to undertake the work. So I've just been blown away by the enthusiasm and the fantastic work that's happened even in a year. Thanks, Alan.
Thank you. Leanne? And then Richard. Still muted, Leanne. Still muted.
Hear me? Yeah, sorry. Yeah, I wasn't muted. It took me a while to come off. Sorry. So I just want to thank everybody for the presentation. It is obviously hugely insightful, and it's so great to see how much has been achieved in a very short space of time. And it is really, I really welcome our colleagues onto our interview panels, and that's happened quite frequently recently, and that's made a really big difference. So just a couple of bits though from me in terms of with regards to reverse mentoring, and I guess the resource to do that. And it's just I guess a plea from my point of view. I applied to have a reverse mentor about a year, 18 months ago, and that's not happened. So I think if we're going to really commit to this, we need to make sure the resource is there to support the enthusiasm from those that would like it. And then aside from that, I wondered whether the REACH group might support me in a further equality and diversity piece, and that's with regards to the removal of banding as a way to describe people. So I have a real passion for not describing people as just A, or I am a band 2, I'm a band 3. It's quite derogatory, it's disrespectful. And rather than have a separate group that picks that up, I think this all belongs into the kind of inclusion piece. So I'd like the opportunity to explore that a bit further if I can before I leave, please. Thank you.
Thank you. Richard.
Thank you. So thank you to everyone that's presented today. Really inspirational stuff. And I felt myself, as Leanne has and a couple of other colleagues have put in the chat on Zoom, a real desire to be involved. And I did feel a little bit jealous of my colleagues who've had this opportunity, to be quite honest. But in terms of keeping it on the table, I want to add to my offer to be part of the reverse mentoring programme. The conversation at the board is developing, and that's fantastic. But we have a number of committees of the board. We have a council of governors. We have forums across all the divisions. And I'd like to offer to be able to put the conversation on the table in those forums as well. And it would be great to hear from everybody on how we might go about that. But that's something I'd like to offer.
Okay, thank you. And finally, Simon, and then we'll come back to Mark, who will no doubt want to respond to some of those issues. Oh, sorry. Let me go to Rabia first. Rabia's hand is up. Rabia first, and then Simon.
Thank you, Chair. I just wanted to pick up on Janet's point first. So, Janet, that's a very valid and very good point. I have been in conversation with university, and we did talk about leadership and management fellowships. And so I will certainly make sure that your suggestion is included definitely. And I just wanted to say, being part of EDI network as board sponsor for overseas staff members, it is absolutely brilliant and humbling, and well done to all the work that's been done. Really great. Thank you.
Okay, thanks. So, and finally, Simon from that.
Firstly, I just wanted to thank, as she's here, my reverse mentor, Rita. You can see her on the screen there. And for putting up with me. It's been a privilege, as I think she knows, but I just wanted to say it with everybody present, because you may not hear my board report in a little while where I called that out. For me, I just wanted to share one of the most, I mean, there's been many moments, but I think that phrase, building bridges, is probably one that resonates with me most. So I've now formed a connection with somebody who I would have probably never met, and quite, from my point of view, quite a deep connection. And you know, it's enabled me to hear voices in the organisation that I otherwise wouldn't have heard. So Rita and I, for example, have been exchanging recently on the fact there's more that we need to do. So next week, with Rita, I'm going along to visit our international nurses and hear about some of their very practical experiences about how we can do better. And that matters too. I mean, this matters, but also some of the basics matter, you know, some of the real basics like housing, food, transportation. And Rita, if you want to say anything, don't feel obliged, but I just wanted to call out the fact that we've still got a journey to go on. And that journey is at board level, but it's also, for me, in the very much the day-to-day of people's lived experience. You know, have I got enough to eat? Can I get to work? Is just the basics of that we all take for granted. We need to remember that some others don't have that level of grace and fortunate in their life. So just wanted to say thanks, really. It's to Rita, and if you want to comment, Rita, that's fine. If you don't, it's also fine.
Okay, I'm assuming Rabia and Richard's hands are old, as is Simon's. Rita, you do want to comment? On you go.
So adding to what Simon has said and what Andy has said, I'm just going to draw from a conversation we had from one of the international nurses at KCC. She made a statement and she said, oh, I've gotten to the stage where I would literally put my stuffs in the middle of Kettering, and you know, someone is definitely going to help and someone is definitely going to hear me. And drawing from what Andy has said, putting it on the table is actually going to get the conversation, get solutions coming. And I really want to thank Simon too for listening and, you know, being a part of this reverse mentoring. He's been very encouraging too, and yeah, it's been wonderful. Thank you.
Okay, thank you very much, everybody. Thank you very much for those of you who've contributed to today. Thank you very much to those who've been reverse mentors. It's a very impressive bit of work. I'm kind of assuming that the board is happy to endorse the agenda for the next 12 months, which came up towards the end of that. Mark, do you want to say anything to finish, or are you happy?
I was just going to say a couple of bits, Alan. So in regards to sexual orientation, Alice, your question, and indeed Leanne around the banding situation, I'm sure I can see Carol on the call, and I'm sure she'd be more than happy to pick those up with you in terms of sexual orientation. Carol, did you just want to give a one-liner as to why that is and what we found as to why people aren't bringing that forward?
In the last year, we've learned, we are on a journey of learning that people have not felt safe enough to disclose everything about themselves. So when we talk about building cultural bridges, we are not only building cultural bridges pertaining to race, we are pertaining to every protected characteristics, and we're encouraging. And one team that's supporting us in this is also the e-workforce team, because they're helping us to reach out to staff on a frequent, more frequent in outlining and saying we don't have this information, we need it on ESR, because they have the power to putting that information on ESR via ESR.
Thank you, Carol. And in regards to colleagues wishing to have reverse mentors, of course, we'll take you up on that offer. We will talk to the team in terms of how we ensure that happens, but nobody's stealing my knowledge, so don't worry, you'll still be my mentor. But we'll work that through for everybody else in the near future. And I think it's just for me then to finally say, Alan, thank you very much to everybody who's contributed to the call today in bringing the presentation together, and that has taught us so much in the programme in the last year. Thank you.
Okay, thank you very much, everybody. You can see that the board is committed to this, and they are adopting the objectives for the coming 12 months. Keep up the good work. Thank you very much, everybody. Right, moving on to the next agenda item as people drop off the call. Minutes of the meeting held on the 28th of May. Are they a fair record of the meeting? Yeah, good. Thank you very much. Chairman's report. I have only got. Is there anything in the action log that anybody wishes to raise that is not progress? No, fine, thank you. Chairman's report. I've got 3 things, and then I've got a little video to show you. So the 3 things are sort of. First of all, we ought to congratulate Amanda Pritchard as her appointment as NHS England Chief Executive. Continuity candidate, as everybody has called her, the current Deputy Chief Exec, and clearly we can expect policy to continue in the same direction as it has done before. So congratulations to Amanda. Secondly, we should congratulate Naomi Eisenstadt, who's been confirmed as the chair of the Integrated Care Board as we move into an ICS in Northamptonshire. So she's been confirmed into that role, and will chair the board when it comes into shadow form and then into effect on the 1st of April. So we all welcome and look to support Naomi in that role. And finally, just to say that at our next public board meeting, we will have a new non-exec director, who is Professor Edmund Burke, who's the current Deputy Vice-Chancellor at Leicester University and part of our continuing linkages, part of the academic strategy, and Professor Burke will be working alongside us to develop the education links in particular. His background is actually in engineering and in education, so we'll be working with him on that. The other thing I want to do is just to mention our governors who were shortlisted to present examples of their awareness work they had done with the Northamptonshire Telegraph at the NHS Providers Governor Focus Conference, which was held in July. And 4 of the governors, Peter Woolscroft, Mabel Blades, David Harland and Andrew Stephen, presented in the showcase, comprising of a short video, which takes about 2 minutes. So I'm going to put it up now, at least somebody is, I trust, and we'll run that video, and then we'll move on into Simon's report. Can we do the video?
During the pandemic, Kettering General Hospital's governors sought different ways to engage with local people, providing information about the availability, access and safety of hospital services and support. It was an opportunity to build on the unprecedented attention on and goodwill towards the NHS. The Trust was keen to promote the hospital, spread key messages and offer insight into its work. With the support of the communications team, the governors approached Northamptonshire Evening Telegraph, for which one governor had previously written some articles. The locally well-known and well-read newspaper published positive and informative pieces, and readers could contact the author to request more information. Colleagues in the communications team checked each article for accuracy, but articles were otherwise unedited. Topics included how the hospital managed personal protective equipment and promoted crisis cafes, which offered face-to-face mental health support. The initiative had positive feedback from staff and local people, with over 100 new members joining the Trust. Information on the local NHS has been used by patient participation groups in education, and a new Governor Comms group was formed.
There we go. Thank you very much for that. So congratulations to Peter and his colleagues who were all part of that. I'm going to just move straight into Simon now. Simon, your Chief Executive report, please.
Thanks, Alan. I've got three things to talk about this morning. Firstly, we've kind of got into it, but it's now in fact a month since we launched the group. And so the first thing I think to do is to reflect on and just to thank everybody who made that day such a success, and who made a real great start for what is our university hospital's mission, because it's a real bet in the longer term. You know, we've got to be the place that attracts staff. Healthcare provision is a competitive market and will continue to be so in terms of where people choose to go, and we've got to make ourselves stand out, and we made a real good job of starting to help ourselves stand out on that day. And I'd particularly like to thank the comms teams who did a fantastic job in terms of lifting that up and making it visible. We had a lot of positive responses, and people were really interested in the press in that university hospital's idea and what it meant for them and for their healthcare. So thanks to the comms teams for all that they did. And we've already started to do the next thing, really, which is to talk about values. And Mark and others were talking about the values of courage and accountability as we start our journey on that. And that's really where we're headed now. We've got to collectively promote, embed, live the values that we talk about. And no more were those displayed than in the conversation we were just having about courage, courage to have the right conversations. Andy brought it out too in that quote, courage. It takes courage to continue to be in the difficult zone rather than just allow things to be as they always are. The second thing I wanted to draw out is a couple of the challenges that we face. So on the first of those challenges, we're at the moment running an extremely hot hospital. As a system, we've been in Opal 3, Opal 4 now for probably most of the last 10 days. And I'm framing that because of the next thing I'm about to say. Yet at the same time, we're trying to deliver an extremely ambitious elective recovery programme and an elective activity programme. That isn't easy. And it really relates to the other point I wanted to make from my report this morning. Traditionally, that challenge would have felt very much one that we had to meet on our own. Before we were a group as Kettering Hospital, now we are a group, maybe just as Kettering and Northampton hospitals. But the other challenge that's implicit and we need to make an explicit virtue of is the need to work together as a system. Some of the problems that we're now dealing with as we exit the pandemic, hopefully, and we move into a long-term recovery of the NHS, some of those problems are now so big we can only solve them together as a system. They are beyond the competence of any one hospital to solve. So if we're going to balance, though, that kind of three-legged stool of delivering for patients, and rightly we should in terms of elective recovery, and then getting back to some form of standards that we had prior to that, maintaining the quality of what we do and making sure that the quality of services are great, and delivering that within a set of financial resources which are constrained. We have to work together as a system. And so the other thing I've kind of majored on in my report is the work of the ICS that we're now doing. Many of you are involved in that. Alan and I spend an awful lot of time on that. And that work, I think now really picks up pace in the second half of the year, because we're moving from a plan stage to an implementation stage. So we'll spend some time later on in the board this morning looking at where we've got to. But that work is now really going to pick up pace and will require many of us around this table to contribute to it in order that we make it the success that we need it to be. Because If we don't, the chances of us having to deal with things more on our own grows. If we make it a real success, we can for the first time create a system in which we are mutually holding each other to account. And my problem is your problem, my success is your success, and vice versa. That's all I wanted to say this morning. Thanks, Alan.
Okay, thank you. I'm going to take Debbie straight into Debbie, and then if there's any questions on all three of those bits, we'll take them then. Debbie.
Thank you, Chair. So I'm going to start today with our new Macmillan support unit. Construction has started in our courtyard for the Macmillan support unit in the just outside of, well, in the middle of the main block. It's due to complete in January next year, and it's fantastic support for our patients who have been diagnosed with cancer or are about to be diagnosed with cancer. So I'm really looking forward to seeing that when it's built. Later on the agenda today, our Director of Nursing, Leanne, is presenting the outcome from the targeted inspection, which was undertaken by the CQC in May. This was in relation to concerns around safety of patients who are at risk of falling in the organisation. What I will say on this is that I'm really proud of the way that our staff have both accepted the report, but more really the fact that they've worked together to make massive changes in such a short space of time to improve the care that we provide for this cohort of patients. It's been quite phenomenal, actually, being able to be part of the work to make those changes. Simon has noted a little bit on recovery and what that means for us as an organisation and as a system. And last month, I visited the outpatient department at Nen Park. It was my first visit there, and what a fantastic facility we've got for our outpatients. Free car parking as well, so really, really good facility, which then obviously leads me on to our recovery post wave 1 and 2 of COVID. This is progressing really well. We are continuing to reduce our waiting times for our patients, as well as improving on the national performance targets, such as 62 days, diagnostics, 52 weeks, etc. Our Chief Operating Officer, Faye, is going to talk more about this later on in the agenda. And working as part of a group, we've also been able to offer additional capacity to Northampton General in the last few weeks with regards to some of their diagnostics. So that's great for the patients of the county. So when I wrote my report, I'm moving on to COVID now. When I wrote my report, we had 12 inpatients. That number has grown. So it went up to 20 inpatients. It's now reduced down to 18. One of those patients is in critical care. The important thing here just to note is that 50% of those patients are actually vaccinated. And this is a really stark reminder to all of us that this virus does not discriminate. So it's really important that we continue to adhere to the rules. And we've all got a duty of care in that, regardless of what role you are in, we have that duty of care both inside the organisation and when we're outside too. So I'll just move on to our staff briefly. During the last couple of months, we have formally thanked some of our people in the organisation and also those outside of the organisation who've supported us through the pandemic. So I would just like to place on record again my sincere thanks to everybody, from the school children who drew pictures for us, to the volunteers who helped us on site, and the members of public who came offering lots of gifts. Massive thank you to you all for all your support through that period. Many of us have got children who have left school or university and they've not been able to have the opportunity to celebrate their achievements. So one of the events that we held was to celebrate our foundation doctors last month, and we celebrated with an afternoon tea for them. We also celebrated our medical staff last month by holding a Professional Excellence Awards event. And whilst it was held virtually, it was really well attended. And it was also a fantastic opportunity to say thank you to many of our staff that you perhaps wouldn't normally reach. It's something that I really enjoyed. I'm going to finish today by touching on our listening events, which are still taking place weekly with the executive team. This week, we had 70 members of staff join us. It's a virtual event, and the focus has now moved much more towards a conversation with our staff rather than just listening and taking away actions. And we had a really good example this week. I don't know if any of you were on the call, but it was a member of staff who'd been waiting for 2 phones to be fitted in an outpatient room. And within the space of 15 minutes, somebody on the call had sorted that out, had the phones delivered and had them fitted. So a really, really good example of staff working together, making decisions and taking action. Next month, you'll see that we are starting to rebrand these events with a new name. We're going to be calling it Let's Talk. We'll have a dedicated intranet page, and there will be different ways for staff to speak up and then take action as well. So I'm really, really excited to continue these, clearly making a difference for our staff and patients, and it's a great opportunity. So I would encourage any of our board members to join on the Wednesday sessions if you're able to. Finally, I'd just like to inform the board that we have made 2 appointments into the executive team in the last couple of months. The first one is Paula Kirkpatrick, who has been acting into the role of HR director. She's now been formally appointed substantively, which is great news. And we've also appointed Fiona Barnes as the interim director of nursing. Fiona's hoping to start in September. Thank you, Chair. I'll stop there.
Okay, thank you very much, everybody. Any comments or questions on any of those things? No. The reminder, some of you know I love numbers, and the reminder about how many of our patients are vaccinated is really just a reflection of the success of the vaccination programme. If everybody was vaccinated, then all our patients would be vaccinated patients with whatever percentage of success. But I was struck by some numbers I was looking at the other day, which says for an 80-year-old male who's double vaccinated with the best of the jabs for 80-year-old men, they have simply reduced their risk to what it would have been if he'd been 50 years old, because this is a heavily age-related thing. So to take Debbie's point, I mean, this is not going away. It is about learning to live with something and to put the constraints in place. So we still have lots of constraints in the hospital despite Freedom Day, and we'll continue to have the vast majority of those for quite some time to come, I'm sure. Right, on that integrated governance report, Debbie, would you like to just orchestrate this all the way through for us, please?
More than happy to, Chair. Okay, so we've got quite a bit to go through in here, but I think in terms of the salient points. So can we start with Quality Committee and Leanne and then Chris, please?
You certainly can. Just pull the. I'm working off one screen, so bear with me. Sorry. Okay, thank you very much. So in relation to the quality part of the agenda today, I think it's quite evident that obviously we're making progress with our falls, and I'll go into more detail regarding that later, and also regarding the CQC report that we've received. Unfortunately, we have had one other never event that was in ophthalmology, and that's within our papers. And actually the issue regarding this was not necessarily ophthalmology in itself, but in terms of diagnostic process and the availability of results and scans. So we're working through the whole root causes of that particular issue. Just to be very clear, the individual that had the wrong injection or wrong eye actually feels that the vision is much better. So we haven't caused any direct harm, but of course one would want to make sure we are getting our processes right. Then with regards to our complaints, we are actually really beginning to make a difference in terms of the turnaround and back to meeting our 15, 30 and 35 and 60 day complaints time responses. And our complaints team are working very closely with the divisions to make many more calls to patients as opposed to the complaints getting into a formal process where they don't necessarily need to, and addressing their concerns at the outset. So I think from a kind of a quality safety perspective, we're doing quite well still at the moment, and these are our main areas of focus. But I think it's fair to say that staffing has been a challenge, particularly with the number of staff now being pinged to isolate, and that is variable on a day-to-day basis. So from a nursing and medical point of view, we review that frequently throughout the day to better understand where our risks might lie and think about how we mitigate that. One particular area that I raised at the Quality Safety Committee and also the group group meeting was in relation to maternity services at Kettering General at the moment. We have a number of staff off, I think it's 28 whole-time equivalents, whilst that number is coming down. And that's in relation to maternity, a couple of vacancies and staff isolating. So we have agreed enhanced bank rates for them. And we're keeping a very close eye on that. And they are reporting their red flags where they need to and escalating. That is it on the risk register of the organisation. And we will be taking a paper to the Group People Committee from KGH and NGH regarding maternity staffing in the next meeting. So thank you very much. Happy to take any questions on the falls, or not falls, on the quality aspects.
Thanks, Leanne. Chris, is there anything that you would like to add in here?
Only to say it's been a busy month during July because we've had actually 3 meetings of the Quality and Safety Committee rather than the usual one. One was an extraordinary meeting to discuss the CQC report and falls, and noting that the CQC accepted that the organisation had taken all appropriate actions as a consequence of the report and that the situation had improved. The second meeting was to deal with the maternity reports that go towards CNST. Very positive reports there. And then finally, we had the normal quality and safety report, and Leanne has mentioned everything arising from that already, so I won't repeat. Thank you.
Thanks, Chris. If we can come in with any other questions at the end, let's move on to Faye and the PF&R and Ops, please.
Thank you, Debbie. So in terms of national position and our national targets, as an organisation, we continue to do really very well and moving in the right direction in terms of our trajectory. So from a RTT point of view, again, we saw an improved position on last month, which is really good. We also saw that none of our patients waited above 52 weeks, again, which is a real achievement, particularly when we look at the national position. As I talked about before, we are striving to work towards 46 weeks for our patients. There will be some patients that choose to wait, and that's their position. But again, we have only had 13 patients in June that waited above 46 weeks. All the others chose to wait. So again, really, really good position. We do need to recognise that our referrals are increasing. Our referrals have been going up month on month. 22% last month, and this is as patients return to their normal kind of position in terms of attending the GP. So we do expect to see that, and we will be keeping a very close eye on that position and how that impacts our performance. Diagnostics, again, another good news story. Whilst we didn't quite hit the target, we just missed that by 1%. We continue to be doing really well across that particular target. So again, really good news for our patients. It was cardiac echo and endoscopy where we seem to have some pressure points in terms of demand, particularly in endoscopy where we're seeing our 2-week wait patients increase, but again, a good position. And as Debbie alluded to, we've also been able to help Northampton out in terms of CT and ultrasound, which is again good for patients across the county. Cancer, again, we're on an improving trajectory, 78.8%. Obviously, we've talked before about sometimes that number will go up and down depending on the number of patients that we treat in our backlog, but our backlog continues to come down. Again, we've got 24, we had 24 patients in June who were in our backlog, 11 of those confirmed cancers, but again, a really good position, and we're on our trajectory to achieve that target in July. So in terms of urgent care and flow, urgent care continue to do a fabulous job, despite the fact that we have seen a 14% increase in our attendances, and that's in comparison to 2019 activity. So certainly hitting that activity levels a lot earlier than we thought we would. Despite that, the team continue to maintain their quality standards and continue to keep flow through the department exceptionally well. Last time we met, I reported that we'd had no ambulance or 60-minute breaches since March. Unfortunately, we had 5 in June. But again, that is a really good position in comparison to where we've been in previous years and where we sit nationally. So really, really good and excellent work from our teams regarding that. In terms of super stranded, again, we've talked about our downward trajectory. Again, we've seen our numbers come down again a consecutive month, which is really good news for our patients. And we've been working really hard with our partners across the system to ensure that happens. Some other things we're just quickly doing around our flow, which will really help our position, is around the second phase of Think 111, which will mean that we need to increase the number of booked appointments for our patients. We're also implementing a surgical SDEC, which will help us stream patients away from the front door into the right place right at the beginning. And we're also doing some work on with our GPs around streaming, again, directly into the right service at the right time. Thank you, Debbie. I'll pause there if there's any more questions. Thank you.
Thank you, Faye. Can we move to John and finance, and then Damien, I'll bring you in after that, if that's okay. John.
Thanks, Debbie. So the finances pretty much bear out the conversations that have been said around operational capacity so far. So at the end of Q1 or month 3, we are £100,000 behind plan. That's with a deficit of £1.6 million, so broadly in line with plan, but with a deficit. We have an expectation for Q2 that we recover back to break even overall. So there are some challenges there, which I'll go through in a second. In terms of the things that are driving that performance, so we have an overperformance on income, i.e. recovered more income than we had planned to. The major driver of that being elective recovery fund, and linking back to the conversations Faye has described around us recovering those elective volumes. That's the manifestation of that. We have some underspends on pay, predominantly in admin areas, offset by some pressures that we're seeing come through around temporary medical and nursing spend. Some of the medical spend is based on putting on that capacity for elective recovery, but a proportion of it also is around us supporting the urgent care pathway and those activity pressures that have been described. And we have some pressures in non-pay, specifically around high cost drugs that we're in the process of reviewing as to whether or not this is an ongoing issue or a one-off or kind of seasonality thing. And that's driving 0.9 million, so £900,000 of our variance on non-pay. So overall in line with plan, but a challenge for Q2 in recovering back to break even overall. The challenges that we have are around an assumption in step up in efficiencies in Q2. So the plan assumed that we delivered £1 million more in Q2, 2 million overall versus 1 million in Q1. That's a challenge we're working through both as a site and across the group, those efficiency programs and delivery against that area. The other major issue really from a planned care point of view is around the elective recovery fund. We were notified as a trust that the rules for this changed. We were notified at the beginning of July that the rules for this changed, and the rules are going to become tougher than we had been told they would be. We have an assumption in our Q2 plan that we would earn around 400k through the elective recovery fund, but of course part of our performance year to date is an overperformance against that. So we have some real challenges there. We've been told that our variation or performance on ERF would be an acceptable variance to plan. So we need to work through what that means with system colleagues and internally. I know there is some work going ahead to ensure that we are pulling all resource that's possible to support that elective recovery, and we are reviewing the performance of those areas that we've already invested in to ensure they're doing what we need them to do. The last point really goes back to those really significant pressures we're seeing on the urgent care pathway. So I entirely expect that we'll need to put further capacity in there to, if the pressures continue as they are, that they are unrelenting. I had a visit around the site only a week ago, and the place was absolutely chocker, and the colleagues I spoke to said this is pretty much unheard of for summer. So we need to work through how we most kind of effectively and sustainably put that resource in to support us over the coming months. On capital, just to kind of round it off, our spend is 1.3 million year to date, which is about 200k off plan, so broadly in line with plan, given where we'd expect it to be.
Thanks, John. You're absolutely right. With regard to urgent care pressures, it's definitely unprecedented at this time of year. So the balance of managing that pressure along with the potential of an increased COVID population and the elective recovery within the financial envelope is definitely a challenge, and one that we've already started to plan across the group and the system. And Simon talked about right at the start how the response has now got to be a system response to this. This is not something that we're able to do alone. Damien, would you like to come in at this point?
Hi, yes, thanks, Debbie. Good morning, everyone. So I'll just go back to some of the things that Faye said, not reiterating the performance statistics that she's already relayed and that are in the report. But the committee noted that the good operational performance is not just this month, it's been a continuing upwards trajectory, and we felt that the board should really take time to reflect on that in a positive way and to celebrate that, because it's no mean feat. And actually, I think thanks need to go to trust employees who have made that a reality. An interesting point that Faye made in the committee meeting, and I think you've alluded to it, Debbie, Simon alluded to it earlier. COVID is still an unknown variable. Winter pressures are not a million miles away. So the system's running hot, I think is the terminology Simon used. It wouldn't take much to start impacting that operational performance in a negative way, and so therefore the system working point that you've made and Simon made is a particularly salient one. A couple of other things I'll talk about which have not as yet been raised. We received a paper on unappointed referrals, which simplistically are patients that are referred to the trust and not discharged but have no future appointment. And clearly COVID has been a factor in driving up those numbers. However, the committee felt that there were some pre-COVID systemic issues that had given rise to these unappointed referrals occurring in the first place. So admin controls, how discharges are handled, etc. And so we received assurance that the body of trust employees that are looking into that issue are also looking at the systemic issues, as well as just dealing with the backlog on unappointed referrals that currently exist. And I think that number is changing. I think the headline number initially, when the issue was surfaced, was something around 40-odd thousand cases. And I think that's been greatly reduced to probably less than 20,000 now, but I think it's a moving feast. We also received the ICANN business case, specifically to approve 1.2 million for the next tranche of funding, which we approved. However, we felt as a committee that probably more work needs to be done to maybe quantify and monetize some of the softer benefits. We felt that the benefits case was potentially very conservative, and therefore, as ICANN unfolds, we think it's really important that we track the actual benefits realization against the money that's being invested. I'd like to suggest that perhaps PF&R is the committee that should provide that oversight, but entirely up to the trust to decide that. I think John covered the money points really well. Nothing additional to add to that, save for the fact that it's tight. That was the overwhelming impression we got. When you then layer in the operational pressures, the COVID situation being uncertain, etc., there's going to have to be a lot of fiscal discipline, I think, to stay within our affordability envelope for the fiscal year. The ability to realise the efficiencies that are assumed within the plan are going to be key. And as you've already said, and John's talked about, working as a system from a financial perspective is as important as working as a system from an operational perspective too, and the two things are very interlinked. But overall, really good committee meeting, and just to once again reflect, it's been a really good performance from the Trust from an operational point of view.
Thank you, Damien. Just one point that I would like to just add with regards to unappointed. So you're right, the paper was really well received, and I think the committee were really pleased with the actions that were being put into place and felt assured that the operational teams were making the required changes. But so I just want to add that these patients are not new patients. These patients have already had an appointment at some point. They are waiting for a follow-up, so a second or third appointment, for example. Okay, is there any questions on finance or performance that anybody would like to ask? Can't see any hands going up. Okay, let's move on to people then. Mark, please.
There's a hand up from Trevor.
Trevor might have a hand up. Yeah.
Okay, it's difficult to see on Teams at times, isn't it? Trevor?
Yeah, sorry, Debbie, it just takes a long time to get the hand to go up. It's age. It's, I don't know, it's finance performance. We've in the past talked about use of private hospital facilities. I didn't know, in terms of how we're managing at the moment, what's our dependence on Woodlands in the current environment, or other private facilities. And second one was about long COVID and what impact is that having on the pressures? You know, it almost seems to be buried in the sort of non-elective workload, but is that a real issue?
Yeah,
I'll maybe deal with the policy position on the independent sector, Trevor, as it's one of my few mastermind specialist subjects. And then ask Polly to comment more locally on the work that we're doing. So from a policy position in Q4, Northamptonshire was the second highest user in the country of the independent sector. Slightly irritating, we weren't top. I can't remember which other system was, but we were pretty much near the top. And that's a tribute to the strength of the relationships that we have locally with our providers, not just with Ramsay, who provide the Woodland, but BMI, who provide 3 shires. So we've got a history of doing well with this. What happened obviously after Q4 was that we went back to the normal cost and volume contracts. And so obviously the private providers are doing more of what they want, as opposed to, and less of what the NHS might want them to do. One of the things I'm pressing for, along with other chief execs, is that we, particularly as we figure forward to winter, that we go back to some form of block contracting arrangement, because even now we can predict with a fair degree of comfort, I think, that winter is going to be extraordinarily difficult, because normally what you would say, you would take where we are now and add 5 or 10% more pressure onto the system for winter. So you've heard colleagues describe a really difficult situation in the here and now. That's set to get worse. So I think you're right to call out that, particularly as we think forward to winter, we will need something different in place in order to maintain elective surgery, which is likely to come under significant pressure. So from a policy point of view, I hope colleagues would support the fact that we need to continue to argue for that form of access to the independent sector. But we did do very well on this. That was the other thing to say. And I'll ask Polly just to talk about the work that's going on in terms of the elective plan.
Yeah, happy to, Simon. So yeah, just to echo what you said, we did do very well, and thanks to our local independent sector partners actually for all the support that they did give to the NHS throughout the pandemic. because some of our, our waiting times are some of the lowest that there are in the country for patients, and that is absolutely due to the support and the good relationship that we had working with them. So we are continuing to work with them. We're continuing to do that in a slightly different way at the moment, but absolutely they are round the table and are part of our system elective care board. So we have already started discussions with them about winter, but not just about winter, but actually what's our long-term relationship look like, because we have a fair amount of elective capacity in this county. What we need to do is make the best use of it across the system for patients. And so it isn't just the independent sector in the traditional way of kind of picking and choosing some of the operations that they want to do. And they are absolutely really happy and want to be part of that conversation going forward. So there's some really good relationships, and we need to just formalise what that looks like over winter and what that looks like into the future. And we are doing that.
Thanks, Polly. Trevor, did you have a further question?
It was about long COVID and whether or not,
That's right,
how much that was impacting on the non-elective work.
Yes, thank you. Rabia, could I bring you in at this point, please, with regards to long COVID?
Yes, Debbie, thank you. Thank you, Trevor. So the long COVID is currently managed in the community. So we've got a well-established clinic. The problem here, Trevor, at the moment is the data and how that drives how much of that is contributing is actually not mature enough to see the exact impact. So I'm afraid to answer your question exactly, I might not be able to do that, to see how much of the activity we are seeing either on the elective activity or even the staffing numbers is related to long COVID. But the last I looked at it last week, so we do have quite a well-established system. So what we are currently looking at is how we can now strengthen the capturing of information and see how it's impacting. But yeah, so there is some work to do over there.
Thanks, Rabia. Can we move on to people now, please? Start with Mark.
Of course, thank you, Debbie. So I got three parts that I wanted to talk to the board about this morning in relation to people. The first is health and wellbeing. So you can see from the report in terms of sickness absence that similar to that of all of the conversation that has gone before, we are seeing the same impact on staff absence, and Leanne mentioned that briefly also. Our staff absence is in a new position now of 5 to 5.5%, and indeed for the month of July has grown based on increase in infection and isolation, which again Leanne mentioned in terms of the pinging of the app. And the impact that that's having on colleagues. But there are also various illnesses, long-term illnesses that are being associated or attributed to the pandemic that we've all suffered and faced. It's a case of people are finding work more stressful and are more anxious in and around the workspace. They were before COVID, it's to be said, but we're seeing some of the impacts of that now. I should say though, on regional benchmarks, so we do look at this, okay, so how are we as a system, how are we against the regional position? We're not an outlier, so I think that's important to bring to the board's attention. In fact, we're in the bottom half in terms of absence percentages over the first quarter and indeed this month of July. But that doesn't mean that we're under any less pressure given all of the operational and challenges that have already been discussed. We do continue to run a fantastically supportive health and wellbeing programme, and indeed we had this across the system towards the back end of June and the beginning of this month with our virtual health and wellbeing festival held once again. This is the second time. Obviously we held it virtually last year, given the constraints, and similarly again this year. And that's something where we come together as a group of colleagues across the health and care system, including social care et al., in terms of making sure that we provide opportunities for people to listen to some specialist advice, to participate, to get something that they can take away and hopefully improve their health and well-being. And we have many colleagues that produce that, but also many celebrities. We had Ruby Wax in this year, we had Gareth Thomas, etc. Lots of people coming to share their stories and experiences with us and to give us some hints, tips, tools and techniques as to what we may be able to do differently moving forward to maintain and look after our health and well-being. The second point that I wanted to discuss that I couldn't not discuss is our vacancy rate. So we can see from the SPC chart, we've waited 2 years to hit the target, and I'm devastated that we're 0.7% away from hitting that target. So hopefully when I come back to speak to you in September, we would have surpassed that. And that's down to the fantastic work of our International Return to Nurse Practice programme. It's also down to some bravery that we've had at board and committee level of investing in this particular programme and making sure that we can bring colleagues in to our organisation, acknowledging that we were going to have some challenges moving forward. So that's fantastic. Of course, Simon and Rita articulated in an earlier item, we still have work to do in socialising and helping and supporting colleagues when they arrive with us in the trust. But to be down at that 7% mark, it stands us in good stead. As I say, we think about the pressures that we have, temporary staff in operations, etc. What would that be like if we were running a 11% vacancy rate position as we were doing this time last year? So that's true testament to everybody involved in that programme. And the third element that I just wanted to raise and discuss is of course how we continue to educate and develop colleagues in the organisation, and that centres around appraisal and statutory and mandatory training, which has suffered over the last year, and we are putting steps in place to try and resolve that, which we talked about in detail at the Joint People Committee on Monday. That was all that was going to be from me, and thank you very much.
Thank you. Janet, is there anything that you'd like to add?
Yeah, thank you. 3 points really. It was a really good joint committee meeting. I am going to highlight 2 specific areas, but the first point I wanted to make is, as you've heard from Mark, some really great development work, all aimed at providing benefits to the workforce experience, which, as you can see, is starting to have some impact, particularly in some areas of the workforce. But ultimately, that impacts on the patient experience too. So really good. The first is around engagement. And Debbie, I just want to reinforce some of the points you highlighted in your report, particularly around the listening events, the executive briefings, the questions and answers, the professional excellence awards. There's so much going on. And again, restarting the pulse surveys in August to gauge staff opinion and morale, I think is a really positive way forward for the organisation. And I think Teresa's arrival in the organisation to further enhance that is going to be a really positive thing for us. The Safe Staffing Report, which has been highlighted potentially by Leanne in the pressures that the workforce are experiencing due to the workload. We have sought, as you've heard, further assurance on the maternity service workforce, and I think that's really important to recognise that we are making sure we're keeping a good focus on that. What has been really significantly helpful for this committee is the work that the medical director has done with her team on the medical and clinical scientist staffing. She was able to bring the paper to highlight the risks and discuss how the impact of those risks are being mitigated, and potentially how that mitigation has some further risk on things like finance. So we were delighted with that, because that's a really big piece of work that the committee have been looking forward to for some time. So thank you, Debbie.
Thank you. I'm conscious of time, but do we have any questions on workforce and people? No. Okay, let's move on then, please. So I think we're now on to the Audit Committee. John, to start, please.
Apologies, Debbie. I don't have a full update from the Audit Committee.
Okay.
Perhaps Trevor's better placed to do that rather than I am in terms of the papers that were discussed. Then, if that's okay, are you okay with that, Trevor?
Thank you.
Yes, fine. Just very briefly, as stated in the report, the annual accounts were approved, and the annual report and the final accounts. One piece of outstanding work, though, from the year-end exercise, which will be tied up in September, is the value for money opinion from the auditors. So we await that, and that will be tied up at the September Audit Committee.
Thank you, Trevor. Shall we move on then to Strategic Development Committee? Polly?
Thanks, Debbie. Yes, much as it says in the update on that slide. So Our HIP2 redevelopment plans are still progressing and going well. We have been given authority to progress with our enabling works. So that's all the work that we need to do to get the site ready for the first phase of our build. So we're just working through the implications of that. There's some demolitions that need to happen. And in particular, there's the energy centre that needs to be constructed and built, which will be really good for the organisation anyway, because that's one of our highest risks, is some of our energy infrastructure across the site. So work continues at pace, and we are also moving forward with developing the work around the outlined business case for the wider site redevelopment. Thank you.
Thank you, Polly. And Alan, is there anything that you would like to add?
No, I'm fine, thanks.
Thank you. Any questions? Let's move on to the Digital Hospital Committee then, please. Andy?
Hi, good morning. Yeah, so good committee meeting. A few things to bring out, and I won't go into the detail of every one of these, but we had a demo of the EDMS system. One of the clinicians came and demoed it, and we're looking to repeat that for our governors because it went down really well. It's not to say that EDMS is not without challenges. We're in a position where we've got much of the hospital still on paper and some starting to have digitized records, and in that hybrid position there's always going to be bumps in the road, and so we sort of talked about some of the things that we'll do to try and address those as we go through, and we will have finished that project in November time, so there's a short period of time where we're going to go through this bumpy period. We talked about the digital aspirant funding timescales and the NGH program, the EPR program. That has an impact on the overall group ambition, but what we've done is to reschedule some of the components of it to try and be able to make some progress on EPMA whilst still going through the digital aspirant funding process. In terms of risk, we've sort of went through the risks, and this month at the operational group we're going through a deep dive of the BAF. A couple of things were noted around the intranet and cardiology imaging, though it feels like we've made some progress on getting the intranet in a good position. I'll hand over to Alice to talk about the people and business continuity elements.
Thanks, Andy. Yeah, absolutely. People-wise, I think we've got a few pressure points at the moment, but we've got some plans in place to address them. We've had 2 heads of business intelligence, unfortunately, across the group who have now departed, and we have interims in place now to address those, which isn't ideal, but we have now filled that gap. And we also have our new digital director, Dan, who started last week, I believe, at Northampton. So we now have a full complement at that level in terms of director level across the piece, which is really welcome. And indications are that Dan is settling in well and making a good start, which is good to know. I think on the people side, other than that, there's then a good initial start to work through the rest of the teams and make sure we've got the right people in the right places across the group now. The other thing to say on that we've done as a group recently is the business continuity exercise, which has taken place, and dealing with any findings coming out of that, which is a welcome exercise to have gone through as a group and benefited from doing it as a group as well, I think. And the other thing to say then is around and next things on the agenda, other than keeping on top of the Northampton issue that Andy's mentioned around the unfortunate delay that's been caused by the funding issue, is that next time we are going to take a deep dive look at cyber security, which I know has been the focus for a number of Ned's questions over recent months. And we've decided to do a deep dive of where we are on that next month or next meeting, which is 2 months, and also a deep dive of where we are on cloud migration, which is another one of our big issues, and make sure we are comfortable with the risk portfolio we've got around those 2 key things which are happening at the moment. Thank you.
Thank you, Alice. Any questions? Otherwise, can we please move on to Collaboration Programme Committee? Simon.
So just unmuting. Just a couple of things from me. Just to note that, and thank everybody for moving the ENT collaboration forward. I think that's really welcome. And it's actually a significant milestone, although it's taken a lot of hard work, many cups of tea and breaking down of social barriers. And I think particularly like to thank Rabia for all the work that she's done on that. I think there are some important lessons that have been learned for the collaborations going forward. And I think we need to think particularly about some of the bigger collaborations that we've got coming up now. For example, around cardiology, we've just this month appointed a clinical director for cardiology, and cardiology is one of those areas in Northamptonshire where we've got a huge opportunity to kind of do something really different and quite transformative, but we need to be under no illusions about the level of work and effort that that's going to take in order to make it happen. But it would be wrong to pass over the ENT moment without saying thanks to everybody who's made that happen. And Rabia, do comment from your perspective if you would like to, because I think your insights into it have been really helpful and your support of it has been fantastic. And then the other thing I'd just highlight here is that Rachel, Alice and I met to have a sort of bit of a forward look as to what the committee needs to do, because I think we need to start structuring the work programme of CPC a little bit more strategically going forward. Maybe if I come perhaps first to Rabia, if there's anything you'd like to add on the ENT issue, because it's been your baby as much as it's been anybody's. So, and then come back to Alice.
Thank you, Simon. I've put in the comment, it was a huge team effort, and it's just ongoing support is required. And I think what really matters most is, as Simon, you said as well, is just getting all those hearts and minds aligned, and just making everybody believe in the shared purpose and value. And I think every other technical thing, whether it's ENT or any other speciality, is all the same. So lots of lessons learned, Polly's help and everything. And I think moving forward, we've definitely got some lessons that we will be tapping onto to do things differently.
Thanks. I'll hand over to Alice just to add her comments.
Yeah, I wouldn't add anything massively, Simon, just to reiterate really that I think Rachel, that my co-chair, and I feel like we've reached the end of phase one, if you like, of CPC's existence, which was getting us to that group model, launching that, and also doing the first few steps of those initial clinical collaboration areas. It's now a bit of a time to, as we've done this week, sit down and say, well, what do we do next? What do we take from what we've learned from that? What do we do next? And how do we do that whilst using the resources of the people on this call appropriately and the equivalent people at Northampton, and not overloading those people, but equally prioritising what we know we need to do now, and not duplicating governance. And that's tricky, but I think we feel we've ticked phase one. Now we need to look afresh at what phase two looks like.
Thank you, Alice, and thank you, Chair. That's the end of the integrated governance.
Okay, thank you very much, everybody. That's a good comprehensive rundown of the issues. When we talked about the IGR yesterday in the Northampton board, we thought a little bit about the work going on in the review of the governance arrangements, which we will talk about in the afternoon session, I think, from memory. Yes, and that's being led by 4 of our directors. John is an exec director, and Rachel was the lead non-exec, but Trevor is on that group, and I think Janet is as well from here. And I suggested that group will almost certainly encourage the committees in common approach to our committees jointly meeting with Northampton, and we clearly can't continue to have just a series of different metrics coming in with different definitions. So I gave the board there a bit of a challenge that by September, we would have a common set of metrics across the 2 integrated governance reports. In fact, we'd have common integrated governance reports by September. Now, I recognise there's a lot of metrics sitting underneath that, and I recognise, as Andy rapidly pointed out to me, that many of them were not calculated in exactly the same way. Nevertheless, Simon, and I'm going to nail him on this one, accepted the challenge and said, I think we can get ourselves pretty much there, at least for the principal metrics that represent risk to the organisation. And I think going forward, if we're going to take advantage of a group model, then much of that is around compare and contrast, and we might at least be comparing the same things and contrasting the same things. In fact, it's kind of indefensible not to be, really. So that's where we're going to go with that. Simon.
Thanks, Alan. Yes, just to re-emphasise, I accepted the challenge that you laid down. I think the first one, and I alluded to in my report, our most expensive real estate is our theatres. And one of the things I want to bring back to the board in September is the first element of real standardisation, and if you kind of like next gen performance management, would be how do we do on our theatre utilisation? What does that look like? And there are lots and lots of metrics where data is spewed out of the system. It's going to take Andy and his team, I know he's blanching a little bit, but a bit of a while to kind of get that into a standard shape. But I'm confident that we will be coming back around the board in September with that report as a kind of key next milestone of how we understand how we're doing. I'm hopeful that PF&R will start to engage with that, because I think it will give you data that you haven't seen before, and data that will be really helpful in starting to understand how well the organisation's doing. And on your point about compare and contrast, that data will be standardised so across the group we can see it. So just wanted to say challenge accepted, and we will crack on.
Lovely, and there's a reference in the chat to the fact that the directors of nursing and medical directors are already pursuing the big ticket items there. Okay, thank you very much, everybody. Just so Faye's aware, I'm going to skip item 6 because my view is that everything in that has been talked about as part of the IGR report. And the good news from that means you now get your coffee break and you can come back at 12 o'clock. So if you wouldn't mind switching off your videos during the break, because otherwise the broadcaster gets into all sorts of mess, I will see you at 12 o'clock. Thank you. Okay, you should all be coming back on now. Okay, it's 12:01. I'm going to assume everybody's there now. As I said, we're skipping item 6. Item 7, I gather that Karen, the Director of Strategy from NGH, is having trouble joining. So, Simon.
So thank you, Alan. If board members can have, if you're following along on admin control, it's page 116 that I am referring to, which is design elements that the boards are asked to endorse. So today we're invited to support the direction of travel that has been articulated by the HCP board. This paper that is in front of you, these design principles, 12 design principles, have been to the HCP board and have been endorsed, but it's important we as boards show our support for them. There are 4 design domains and 12 principles that are set out in front of you today. They should be familiar to many of you because they are items that we have discussed both in public and also in our development sessions, but to say very briefly, the first is collaboratives, which is the principal vehicle of how we're going to deliver services at a system level. And we in our space will be leading the development of the collaboratives jointly with NHFT, and specifically leading the development of the elective collaborative. And Polly will be our point person on that. Then on place, we will have 2 places, West Northants and North Northants, which align with the footprints of the unitary authorities. Our local authority chief execs will lead the development of those arrangements. I would say in terms of place, that's the least well-developed part of our narrative at the moment. We are pretty clear how we will deliver things across the system, but we have to make sense of what does place mean. And I think that's where we're going to be spending quite a lot of our development time in the months ahead. The same for neighbourhood. And really, we're now starting to think at very local levels when we talk about neighbourhood and trying to understand what local communities want. And then lastly, we should be reminded of the fact that this is a significant statutory transition as well as being a service change. So to remind everybody that these bullet points 9 through 12 refer to the dissolution of the CCG and the establishment of the ICS statutory body. I guess the key point there, I would say, is the construction of that, I think, is going to be quite a complex piece of work that will tax us, Alan and me, particularly on your behalf, in the months ahead, because we're moving from a system which over the last 15 years, everybody has got very used to, which is commissioners commission and providers provide. And there's a contract that links the two of them. And often those conversations are quite adversarial and confrontational to an approach where we are roped together. So in simple terms, on that ICS statutory body, we would be a partner sitting round the board table. That represents probably the single most significant departure from the way in which we have done business over the last, certainly the last 10 years and beyond. All of these areas, it should be stressed, need further development and work. I've kind of highlighted some of the development areas, but all of them do. So in approving this today, you're approving a direction of travel, not a final set of proposals. and you're acknowledging that there is further work that needs to be done. And our lead overall across the group for that is Karen Spellman. And as I said, many of you will be involved in those next 4 phases of work. But for today, Alan, the board's invited to approve those principles, make any comments that it wishes us, you and I particularly, to feed back to the HCP board, and look forward to the work that we need to do in September. That's all I wanted to say.
Thank you very much, Simon. Quite a lot of our non-execs have been involved in the work up to now on this. However, any comments or questions before we move to adopt them, approve them? Trevor, I know when you lean forward, it means you're pressing your button. So, Trevor.
Thank you, Alan. Yes, unfortunately, I've got mine at the top of the screen, so it sort of involves me leaning across the screen. It was about potential, I'm not saying real, but potential issues that might arise, and just being alerted to them up front, where we're talking place. We could end up with that phrase we've used in the past in the NHS, postcode lottery, that actually we're going to end up with different services at different places in the county, and in doing that, how we as an organisation respond, or as a group respond to that, particularly as we are uniting some of our clinical services. We may have different calls on our services in the north and the south, just as we have at the moment and have historically had. And an example, most obvious one, is the way that paediatrics is delivered in Northampton and Kettering is very different. But we may see more of that going forward, rather than actually, as we might have hoped, a more sort of unitary approach to the whole of our care.
Okay. Any other comments or questions before I just let Simon answer anything else anybody wants? Chris.
Thank you, Alan. I was just going to ask, are we all comfortable that the central role of hospitals in the system in the future is ensured in the current structures, or is it an area for further development?
Okay, if I take those two in turn. So the first answer to your question, Chris, is no and yes, simultaneously. So no, it's not yet been clarified, and yes, it's an area for further development work. Okay. And just this week, and at our ICS development group next week, I'll be talking through how we answer that question in more detail. The mechanicking of this is actually really quite key. We all know who've been around the health service for a bit, that if you get these hardwiring choices wrong, you live with them for a very long time and you repent at leisure. So the reason why I'm calling it out here, and why I called it out indeed in my report, is because I think it's absolutely essential that people like me put quite a lot of time alongside colleagues into making this work for us. So no and yes is the answer to your question. On your point, Trevor, yes, that's a risk. We've seen, we have got 2 new unitary authorities. They naturally want to serve the populations that they are gathered around in geographical areas. However, we have to reconcile that desire with a desire from a health service point of view that says, in actual fact, given the challenges we face, aggregation is a more sensible strategy to follow. And we don't yet have a way of reconciling that either, other than to say it has to fall into the next phase of work. So if I give our practical example of that, and maybe Polly might wish to comment, would be, how do we make sure that in delivering the elective collaborative, we actually equalise services across the patch? That will be a test for us to define, because at the moment we've got an inequitable position on some of our waiting lists. So if you are in Northampton, you are still likely to wait longer for elective surgery at the moment than you are if you are in Kettering, where, as Bay has already more than amply demonstrated, we've done really quite well. So some of that resolving that challenge is all I wanted to put, the point I wanted to make is within our gift to define what the answer might look like.
Okay, thank you, guys. We have quite a long session, or quite a long bit of the August development session on what do we want out of the elective collaborative. And Polly will, I think I recall, will be leading that in August. So there's quite a lot of room for a conversation here about how that works. Lisa.
No, it was just to quickly to add, and I know it's been said before, but just to reinforce, you know, this programme, it's not just a governance programme, it is a cultural change programme for the whole of Northamptonshire. And I think, therefore, we need to go into it understanding not only the size of the prize, but also, Simon, you've alluded to your time, but I think we also just need to note formally, you know, this is going to be a draw on everyone's time, and that by approving the framework that we've got presented in front of us, that we are committing to, you know, drive that through to its natural conclusion. Right.
I agree with both of your points. It is a huge cultural change programme, no more so than in bullet points 9 through 12 in that page, because I was trying to draw that out, but I will make it even more explicit. You know, we've had a commissioning provision culture that has not been orientated in the way that those bullet points now say. And just saying that we're going to do something different does not mean it will happen. It's going to be a really active process. And many people around this table will be involved in helping that happen, because it has to exist at a governance level, a clinical level, a financial level, and an operational level. And all of those have to come together in order to make this programme, as you say, Lisa, of cultural change a success. But I hope what people have got in front of here is that, given the work that we've done, the socialisation that we've had, you would feel able to approve this as a direction of travel, noting those caveats that we still have work to do on. And you'll get a chance in your August development session to have a much more detailed look at what an elective collaborative is and how it fits into what we are talking about here.
Thank you. I think the other point, the point you make, which is about demands on people's time, Lisa, I'm very clear that the work we're doing on reviewing governance arrangements, one of the driving forces for that is to make best use of non-exec directors' time, because there will be work to be done in the ICS space as well as the 2 trust space. But I'm also extremely aware that our non-exec directors are non-exec directors of this hospital. They are not non-exec directors of these hospitals. And that produces a very particular liability for them. We need to think very carefully about how they fulfill all of those roles as they go forward. So we will be talking about that a lot in August and in the non-exec director lady in September. So on that basis, I'm assuming we can approve those design elements that you're asked to endorse. I haven't heard any dissent from that. Good, thank you very much. Freedom to speak up. Susan Clennett is not here, able to be with us today. So Richard Apps is taking this one. Richard.
Okay, thank you, Alan. So yes, Susan's not with us today. She's taking a well-deserved break from work. But the first thing to say in introducing the annual report is thank you very much to Susan as our Freedom to Speak Up guardian for all of the work that she has led in the last year. And I want to say a couple of other thanks before I highlight a couple of the other things in the report. Firstly is thank you to Tracy Lynch, who is our Freedom to Speak Up Champion of the Year. Trevor, as the non-executive lead for Freedom to Speak Up, did a virtual award ceremony, which we managed to couple with a real live somebody jumping into her office and socially distanced giving her the award, which was a good shock and surprise for her, but really well deserved. Tracy's done some fantastic work this year. And then thirdly, to highlight, board members will know, because I've said this before, I think there's an irony in freedom to speak up in that its success will mean its demise. If staff are empowered to speak up through their line managers, then the freedom to speak up champion and freedom to speak up guardian roles will make themselves redundant, and that's the cultural ambition that we want to achieve. And I think Carol touched on some of that in the presentation we had this morning around equality, diversity and inclusion. But this year, Sarah Parry, who's our end of life lead nurse and a freedom to speak up champion, has done some fantastic work supporting staff to have difficult conversations with their line manager, and just being able to support them rather than take a different route through freedom to speak up to get issues resolved. So that's fantastic. In the last year, of course, it's been a really challenging year as far as the pandemic is concerned, and our number of concerns has gone up during that year. Most of that, in terms of thematically around COVID, has been around people just being confused. What is the guidance? How do I know? Please help me, please signpost me, please help me understand and feel safe. And I'm really pleased to say that we've done an awful lot of work to help and support people manage the guidance, particularly national guidance as it changed and was implemented through the hospital. And then lastly, just to highlight in the report, colleagues will know that there is a national benchmarking index for speaking up, which takes data from the national staff surveys, takes data from incident reporting and others, and the trust score has improved a little bit this year and puts us right in the middle of the pack. And there is a publicly available report from the National Guardian's Office that puts all of the trusts in order, and we're very comfortably doing well in that. I'll stop there, invite Trevor to comment if he wishes as the non-executive lead for speaking up, and take questions. Thank you.
I think two points really. One is that the work which we heard of, it was touched on earlier in our EDI conversation, of the BAME Freedom to Speak Up champions has made an inroad into enabling particularly our BAME staff being able to speak up, whereas in the past maybe they wouldn't have done so. My second point's on Richard's, the success of Freedom to Speak Up is its demise. I sound caution on that. I think Freedom to Speak Up is there. How much it's used may actually come down, but I think we still have a way to go on that. And whilst we may see reductions in this year's number of reports, because we haven't got sort of some of the issues we had last year around the first wave of the pandemic, other issues that come through, such as, you know, the way the group will impact on wards and departments, how rebuilds will impact, will introduce new lines that may get raised. But I also want to thank Susan for her hard work. I know she can't be here today, but it has, you know, her briefings have been extremely useful in terms of the insight, in terms of the themes and what needs to be done to support it going forward.
Okay, thank you very much. Anybody else want to ask, pick up anything on this or comment on it? It's a normal annual report coming to the board. Lisa.
Yeah, it was just a quick one. It was picking up on the comment about some of the underlying factors coming back to COVID and the extra pressures, and appreciate that obviously all staff are under the extra pressures. But in the context of a Freedom to Speak Up report, I don't think we can accept COVID as an excuse. That may be the reason for the issues, but it cannot be an excuse for the issues. So I just don't want us to walk past the fact that COVID cannot excuse, and I think we need to understand the reasons behind the rise in some of these things, not just the additional pressures.
Yes, I think I'd agree with that entirely. Any other thoughts at all? No. Okay, so bearing in mind those comments, we take the report as accepted. Freedom to Speak Up. People Plan Pledge, Mark.
Thank you, Alan. So in terms of the People Plan Pledge in relation to people partnering, as part of the People Plan in March, one of the tasks around that was to look at our disciplinary policy, and the intention to look at our disciplinary policy was based on some learning that we've undertaken from some cases that have been managed in in KGH, but also in NGH in the recent past, making sure that we learn from some of those issues that have arisen during those cases, and we take appropriate or different action in the future, and we don't put colleagues through the same process that we had done historically, perhaps. We also had some national learning. So Baroness Harding wrote out to us just prior to the pandemic in relation to some learning that was undertaken from a trust in London, and how the disciplinary policy had affected a colleague so severely that they took their own life in that particular instance. And so we very much were looking and have been looking at our policy in terms of making sure we can make it as supportive as possible, and less bureaucratic, essentially. And we've now done that together across the group. So what you have in front of you for review today is our policy and where we are at with it at the moment. There are some elements that we're still working through, which I thank our staff side colleagues and indeed some of the people within my team and indeed the management team to work through, which is the operational appendices in some of these items. But what we have done is that we are very much trying to take a more just and restorative approach in managing disciplinary cases. Nobody turns up to work in the hope that they'll make a mistake or intentionally to create a bad situation, but unfortunately they do happen. And when they do, we need to take action. But it's just the appropriateness and the formality of that action and the speed of that action could be improved, and we're trying to do that within the policy. As I say, in terms of taking it forward, we have an action plan and a table within the content of the report too, and we have both staff side meetings next week, so Wednesday in KGH and Thursday in NGH, whereby we'll take forward this policy and hoping to approve those operational appendices and then place the policy on our website. This will be the first of many across the group. I think it's one of the benefits of being a group of 2 hospital trusts working together, that we don't duplicate effort in the creation of these policies, and we make sure we take the learning from each organisation too. And it will also help obviously with the transition of colleagues working between both hospitals, that we have a consistent and similar set of policies. Happy to take any questions and queries or comments. Thank you.
Okay, anybody pick up anything from that at all? No. Okay, Mark, I think you can assume that that has been adopted. Now I've got a bit of a conundrum now, because Leanne's Falls people are joining at 12:28, and there's very little on the agenda that is worth pursuing that can do in the next 3 or 4 minutes, I suspect.
Alan, we can start, and then when they join, because they're in essence they're talking about what it's felt like for them. So as soon as they join, I'll go through the presentation first, and because I've talked them through that, what I'm going to do anyway, and then they'll be able to share their experience at the end, if that's okay with everybody.
That's absolutely fine, Leanne. Thank you very much for resolving my problem. Off you.
If only all problems were quite so easy. Okay, thank you. So in your packs today, you will have received the CQC outcome report. And obviously there's a lot of detail in there, and it absolutely doesn't make for pleasant reading in terms of the situation we found ourselves in as an organisation with regards to falls. So I think firstly, before I do the presentation, it's fair just to think about why we think we've ended up in this position. And I go back to, unfortunately, we did have a COVID situation over the last year, which is absolutely not the sole reason for the challenges that we face with regards to falls. However, there are a number of things that are changed throughout that process or that time that I think have impacted on that. So, and I think firstly, staffing absolutely throughout the last year, 18 months has been a challenge, but particularly in that we've moved staff around the organisation and they've been working in unfamiliar areas, so aren't necessarily cognizant of the individual environmental challenges that are in specific areas. So for example, an outpatients nurse going to work on a ward, very, very different environment to one that they would historically been used to working in. We've had a number of staffing gaps, and therefore our ability to observe patients as closely as we like was definitely challenged, despite us trying to move staff around the organisation as much as we could. And on a reverse to that, we've actually had an awful lot of new starters, which has been brilliant. But of course, we didn't have a formal induction programme throughout the last year. And a lot of those new starters needed ward level induction at times when the substantive staffing was not at it as perhaps it would have been prior to COVID. So there's a couple of elements there. And I think environmentally, we introduced a lot of changes. So big plastic screens in places that make life very, very difficult to navigate and negotiate in terms of getting around an environment. And a lot more environment became cluttered as a consequence of that. So that makes it quite difficult. And then couple that with staff that don't work in that area, the situational awareness is further challenged. Documentation was absolutely an issue for us, and it's what really has become very clear and very evident is how unwieldy our current documentation was. I'll go into what we've done with that in a while. It's not logical to follow, and there was a plan to update it, but of course we didn't get around to updating that in time. Couple that then with, or overlay that with, the situation with governance light throughout the last year, 18 months. And I think a lot of the audits were being undertaken by staff in their local area. So we received some false assurance with regards to compliance with the metrics. And we weren't looking as deeply as we have done subsequent to the issues arising. Despite the falls summits, etc., and our number of our falls coming down, we did unfortunately have 3 patients that died in our care as a consequence of falls, which absolutely we had been raising as a concern for ourselves and had started to do that deep dive work. However, in reporting to our board, but also to the CQC and to the CCG, of course, that raises attention and a focus. So hence the unannounced inspection by the CQC. So I think it's multifaceted as to why we've ended up in this situation, but I'll be pleased to share with you the journey we've been on in a very short space of time to rectify that and to bring our number of falls down. So if I could have the first slide, please, Victoria. Thank you very much. If I can go on to the second one. Okay, so the CQC carried out their focused inspection due to the concerns raised regarding falls at Kettering General Hospital, and that was on the 4th and 5th of May. What that looked like was a series of, well, firstly, they looked at 6 ward areas. Some of those double up, so therefore it reports as 9 in the final report. And they also spoke to staff that were in those practice areas, and also to the leadership team and the falls leads in the organisation. It became very quickly evident that there were some gaps in our knowledge and understanding and some issues that were being raised by the CQC. So immediately we set about setting up task and finish groups to begin to address the issues and the concerns that were being raised. On the 13th of May, as part of the CQC regulatory process, we received a warning notice, a 29A warning notice, which set out 8 must-dos and 3 should-dos. We were already on with addressing those, as I say, through the task and finish groups, and we've been able, as we've gone along, to share our progress with the CQC. So we introduced really robust action plans, weekly point prevalence and audit done by peer reviewers, because I talked before about audits being undertaken by staff in the local area, not necessarily getting under the skin of the root causes of the issues that we were facing. And we introduced a robust governance process for monitoring and reporting on the improvements that were being made. On the 8th of June, we received our draft inspection report, through which we were able to just return a factual accuracy back to the CQC with additional evidence. And then we finally received the report that you have in your packs today on the 7th of July. And obviously subsequently that was published in the local media, and we did some comms in regards to that. Next slide, please. So in relation to the report, the outcome of the report in terms of rating, you will see at the top of the screen, the medicine core division was previously in a requires improvement rated position by the CQC. As a consequence of the report and their findings regarding falls, then that led to an inadequate rating. That does not change the rating for the organisation. What we're doing and working with the CQC now is to invite them back in when they are available to re-inspect falls in the organisation, so we can turn that back to an RI. If they only come and do a focused inspection, we can only get back to an RI. If they come and do a comprehensive inspection, then we can change the rating more globally. but that's where we are with that. But I think the media initially published that it changed the rating of the trust. It didn't. It changed the rating of the medicine core division. Disappointing as that is, and certainly the team have felt that. Next slide, please. So long list here of the must-dos, and if you've looked at the report, you'll be very well cited on these, and obviously we've taken action around them. But in essence, what the CQC found is that whilst there were systems and processes in place, they weren't being followed consistently, and that staff weren't able to articulate how or why they were following them or what actions they were taking as a consequence of those. And in terms of the situational awareness, that was definitely something that was raised. So next slide, please. And these were the should do's, and this was very much around safe staffing, making sure we got peer review audits in place as opposed to local audits being undertaken, and the challenge regarding our documentation and some of our environment, as we said. The staffing is an interesting one, and we spent a lot of time looking at our staffing levels, and certainly for your assurance here, we, from a nursing perspective, undertake a staffing cell twice a day, where we identify any risks or gaps that exist, and we further improve that with making a direct link to the staffing cell each day to the falls risks in the organisation, so we can allocate additional resources accordingly. Next slide, please. So this slide just sets out the working parties that we immediately formed on the CQC just as they left just after the 5th of May. So the groups that we've had in place are looking at the falls risk assessment and care planning, the bed rails risk assessment, tagging, and tagging essentially is where you've got a patient or patients at risk, that they are in direct eyesight and line of action and response from a member of staff, that we have in place greater and more robust processes regarding learning from incidences, that we have a very clear and robust and one means of capturing the data regarding lying and standing blood pressure. This is a risk for patients who have what we call a postural drop. So when you stand up, your blood pressure drops, then of course it contributes to the falls risk. We looked at then what digital solutions there were in terms of handing over between staff, between shifts, between ward moves, and then the patient level risk assessment and the audit that we had in place. To oversee that, we were very clear about what audit measures we were going to put in place, and we have a 21 point prevalence audit that's done on 100% of patients at a given time, which is a mammoth undertaking, but actually it's really helped us understand the root causes of what we're looking at and therefore what we've got to act on. And the peer review audit process has been established, so staff are not doing their own ward areas, they are being peer reviewed, and that's further overlaid by additional scrutiny from the practice development team. And we also do objective sampling of the audit, and we question every audit result that we get. We meet on a Friday morning, we look at the data that's come in for that week, and where we've got either fast improvements or some variation in terms of a deterioration, we seek to understand what that looks like. And then on top of that, or as part of this, of course, we've really invested in staff engagement, and Debbie mentioned at the beginning the weekly listening events, and this was really a means by which we can ask the question, what helps you to be the best you can be every day? And if things like documentation, the environment, etc., are getting in the way of delivering best practice and best patient care, we need to understand that, and that's what we've been working on. Next step, please. Next step, next slide even. I'm not going to go through every one of these slides, but just to give you an overview of, on the left-hand side, you can see what the CQC said about the organisation and practice and what we've been doing on the right-hand side. So in terms of the falls risk assessment and care planning, we've used recognised tools that have been used nationally. Everything that we've developed has been in relationship and in collaboration with our staff. So they have helped design the final documents through a plan, do, study, act process methodology, and we've also piloted it in all divisions. There has been additional training implemented through videos, daily training sessions, practice development team being out and about in practice to help staff understand what the ask is and how they can better safeguard their patients from falls. Next one, please. This was a significant one that was raised by the CQC, and it's regarding bed rails and the use of bed rails. Now, you might think that if someone is restless, that bed rails might be the best solution for that patient. Generally, they're not. So where patients lack cognitive ability or they have behavioural challenges, then the bed rails are not best placed. So it was helping staff to really understand how they assess the risk for each individual patient, how they judge the need for bed rails, and how we acted on that information. So a whole new tool has been designed that the staff, as I say, have developed, and that is now working 99.5% of the organisation. We find the odd old tool, but that's all being cleared out of the organisation. And again, we've had education and training regarding this particular use and this particular practice. And we also have an indicator across the organisation of digital bed rail magnets on the virtual ward system as well, so people can see at a glance who needs to have bed rails up or not. So it's quite easy when you're doing an audit to see who should and who shouldn't, and question whether if the opposite is in place. Next one, please. As I said, I won't go through all of these, but this was another significant one, and this is regarding the tagging, which I described earlier. Historically, we had in the organisation a process of cohorting and tagging, whereby all falls risk patients were cohorted in 1 or 2 bays of a ward, and staff were therefore allocated to those bays. What that makes it really difficult for an individual to observe every 5 to 6 patients who are all particularly restless or at risk of falling. So what we've done now is made sure that we tag those bays where there are patients at risk, and it makes it much easier. You then got in a bay a mixture of patients that are self-caring, some that are at greater risk, so it makes it much easier to observe. And we've put a new standard operating process in place, so staff are very clear. Again, training videos, and on bays there's a big clear yellow sign that says this bay is tagged, and you can observe whether or not there are observers and staff in those bays. And as I said, we've linked this to our staffing cell as well. One of the other areas that we've changed is putting curtains in bathrooms and toilets. Now, all of you, if you use a bathroom, will probably say, no, I don't want somebody to stand in the bathroom with me, and people absolutely have the right to do that. But where people lack ability to make that decision, that can be a real challenge. And so we're asking staff to protect patients' privacy and dignity by standing behind a screen or a curtain whilst a patient is using the toilet. And that way you can hear when people start to move, because we had been experiencing unwitnessed falls, and particularly in our bathrooms. So we've made that change. Next one, please. So I won't go into this one. This is regarding the falls care bundle and all the information that kind of pulls together to manage falls and mitigate risk. Next one, please. Serious incident investigation and learning stream. This was very much around where we have had instances of falls in the organisation. Did we really get under the skin of why that had happened? What was the true root cause? So we've been investing a lot more time in understanding that, and therefore being able to share the learning as a consequence. Next one, please. You've done a lot now in terms of the digital handover, so all the audits and the risk assessments are in one place, and as we move towards an electronic patient handover, that will certainly help future documentation as well. Next one. So I think it was just right that we also say that where we recognise we had risks with the falls regarding documentation, practice, etc., we wanted to make sure that we didn't have the same issues across other elements of our practice. So the methodology that we've applied to the falls, risk assessments and practice, we are doing the same now for pressure ulceration, risks and Mental Capacity Act, sepsis and venous thromboembolism. So there's a number of work streams that are ongoing at the moment to test ourselves to understand whether the same risks are associated with these practices as they were with our falls. At this moment in time, it doesn't appear to be with the work that we've done, but of course, we're just in our benchmarking and baselining part of that process. Next slide, please. So I mentioned at the beginning that we have for falls a weekly 21.100% patient audit on a point prevalence. And we know that that's not sustainable going forward, because it is really tying our staff up a good 3 to 4 hours a week that's a number of staff to undertake this audit, but it does help us understand our practice. So we're now moving forward to using the Perfect Ward, which is an app with a set of questions that will be peer reviewed and we'll be moving away from those local kind of audits into a more formalised route that will still get us to a point where we truly understand where the gaps in our practice are, but at a glance. So that is being rolled out as we speak. And next one, please. Thank you. And I talked a bit about the staff engagement earlier. So hopefully, I can't see actually because I've got the screen open. Have my colleagues joined me? Have we got Andrew? Ah, great. Thank you.
Andrew, Gillian and Tina are all here.
Brilliant. Thank you. So Andrew, I'll invite you to speak first, please. If you introduce yourself. And if you just talk about your experiences as one of the falls leads and the work that you've been doing with the Perfect Ward, please.
Yep, thank you, Leanne, and good morning, everyone. My name's Andy McGovern, and I joined the Trust just over a year ago now, and I've been so impressed with the way colleagues have all engaged together to drive forward these improvements, and it's been a really, really positive experience in the face of adversity. So I led the Falls Risk Assessment and Care Plan part of the work and led the task and finish group. We used a quality improvement approach and redesigned the document and ran 3 PDSA cycles on 4 areas. Following that, we signed off the documentation and upscaled to the whole hospital and rolled it out, I think about 3-4 weeks ago now. Following the regular point prevalence audits, we identified there were still issues that probably weren't identified with a small sample, but when we moved up to all hospital level, there were issues that staff raised, and there were issues identified in the audit. And we responded to those concerns. We reconsulted on changes. We're due to run PDSA cycles again next week. And I think it's important to say this is very much work that's been led and guided by feedback from operational staff. And we've always been mindful of their concerns. I think we've taken a pragmatic, honest and collaborative approach, which I believe is really going to set us in good stead going forward with our new documentation and processes.
Thank you, Andrew. That's really, really helpful. Thank you. We'll take some questions at the end, but thank you. So Gillian, I'd like to bring you in, please. If you introduce yourself.
Hello, so my name's Gillian Floody. I'm the Quality Improvement Matron in Medicine. So I think similar-ish things to what Andy has said. So obviously the engagement has been fantastic, I think, across the board. We've worked at quite pace with training, with working groups, which there were some really good conversations that were held in those. So I was part of the tagging working group, and the conversations that came out of that were really interesting. And we did have all kind of AHP. So we had therapies, we had our Admiral nurse specialist in there. We had people from urgent care, medicine, surgery. So it was really good conversations that came out of that. I think as well our digital involvement. So all of us have thought not only what we can do to change things, but also how we can still include this in our digital work stream that we're working towards. I think our ward teams, at times we have confused them because we have put a lot at them quite quickly. However, they've all been really receptive to the change that we've been doing, and they're very aware it's still an ongoing process. So we have had feedback, which every working group has taken on board and incorporated into their things, and obviously things are still evolving. And then the only other thing I wanted to say was for medicine, that obviously my role is quite new. So I came into post in May, and we actually have a dedicated quality improvement team that are working quite closely with our practice development. So there's myself and 2 quality improvement sisters, and we're working with our wards daily. And obviously it was medicines inspection. So they're working quite well out there.
Thank you very much, Gillian. And Tina.
Hello, I'm Tina Coe. I'm matron for trauma and orthopaedics, but I've been really engaged in this process ever since the start about 9-10 weeks ago. What we realised in surgery was, although it was the medical division's inspection, that could so easily have been us in surgery. When we started to review our documentation, we were probably at the same level that medicine were. So over the last 9-10 weeks, we've worked really hard with our teams. We've had fantastic engagement from the teams on the wards. Our sisters and charge nurses have been part of the work streams for the bed rails and the falls audit. Yes, and I think the one thing that has really been noticeable over the last few weeks is that staff have been listened to. I think Gillian was right. We have we did confuse staff because we introduced a new bed rails tool. We introduced a new falls risk tool in a really quick timeline. And I think we have listened to our staff, and we are now revisiting the falls risk tool, which I think is great because it's showing the staff that we are listening to them. I think we've come a long way in the last 9 weeks. Within surgery, we haven't got a quality matron as such, but the matrons pick up on this. We have a regular Friday afternoon, it's called Surgery's Patient Quality Forum, where we pick up and we share the results of the overarching CQC audit, if you like, and we drill down on the areas that we've not been quite so good at. And again, from a matron perspective, we are really engaged. I mean, we audit our wards every week, and as Leanne said, you know, to do a ward of 24 patients, to do it properly, engage with your patients, engage with your staff, you're talking 2 to 3 hours per ward. But we understand how important that is to make the improvements that, you know, we needed.
Thank you very much, Tina. Thank you very much, Andrew, Gillian and Tina for joining me with this. So we'll take some questions in a minute, but actually what I'd just like to reflect now, and if you have the next slide, is what impact has this had? Because that's the important point. So what's the output of this? So we've really focused on making sure that our falls associated with our admissions in care have come down. And hopefully we'll go on to that data in just a moment. But you can see there from the charts, particularly those that are at the bottom, where we were with the compliance with our documentation, our bed rails risk assessments, tagging, etc., and where we are now. Now, in terms of the falls care bundle, that's because we've introduced another new practice in there, and there's some misunderstanding with regards to what's expected in that documentation. So in the next week or so, we're hoping to see a vast improvement in that particular aspect. But I think you'd share my view that over a very, very short space of time, we quickly and rapidly saw improvement, and we've been able to largely sustain that. So I'm really, really immensely proud of everybody in that short space of time. Next slide, please. Is it stuck? That's it. Lovely. Thank you. So again, the output from this, or the outcome, has been that we have seen a steady decline in all falls in the organisation. The number of moderate falls and moderate harm and above falls has come down all bar one in July. And then the T chart at the bottom just starts to describe the time frame between falls, and we're hoping to see those dots move further apart as time goes on. So therefore there'll be less frequency of falls with moderate and harm, moderate and above harm. Can't speak this morning. Thank you. And the next slide, please. Okay, and again, the weekly analysis will show that, again, it's coming down. We did have 12 falls last week. 6 of those were in our urgent care area, so we're doing a focused piece of work in that. None of those falls were with harm, thankfully, and therefore you can see that bottom left-hand chart that the harm profile is remaining low or down. And one big bit is regarding that witness versus unwitnessed view. So as I mentioned earlier, we were experiencing a number of unwitnessed falls. We're now largely seeing any falls, or most of our falls, as witnessed ones, which gives us a great indication as to understanding what our patients' needs requirements are at the time, and where we need to focus our attention. So you can take the slides down. That's great. Thank you. So we'll go back to questions in a minute, but I'd just like to finish on Richard and I met with the CQC this week, and we presented this data and some further information to them. And we talked very much around the cultural aspects. And I think the team have been able to just clearly describe how engaged everybody has been in the organisation. I think the data shows you that very quickly staff acted with accountability and integrity and got on with it and knew that there was an issue. So, you know, I'm immensely proud that they've managed to do that. In talking to the CQC, the feedback from them was, this is impressive. So it was, I have to hang on to that word. It's a great word to use. They can see very clearly from the data we're providing every week that staff have got behind this. We've acted. We know what our issues were. We know what we've got to do to turn the dial on that. And the output for our patients is that it's far safer than it was previous to these processes being changed. So I think everybody's acted very well within our core values as an organisation and acted, say, totally with integrity and accountability. So I'd just like to thank everybody, and we're happy to take any questions. Thank you.
Thank you, Leanne. Thank you, everybody, for your contributions to that. Chris, Chair of Audit, Quality and Safety, would you like to comment on that from the committee point of view?
Yes, thank you, Alan. A couple of comments. First of all, I think the thing that I want to start with is to say thank you to Leanne, Debbie and Simon for their leadership in the response to this situation. And also, I think a huge thank you to all the staff who've been involved, because it is very clear that they have, as Leanne said, acted with integrity and alacrity in changing the situation. What's the committee learned from this situation? Well, I think the big message is that in the first half of 2019, the number of falls with harm was pretty low. And then we had a spike, and we then started discussions about falls at each of the meetings. And as far as I can count up from the records I keep, we've discussed falls on 11 of 13 occasions that we've met. So it isn't that we haven't discussed it, but I think the phenomenon that we've really put our finger on now is the whole issue of false assurance, and that you can discuss an issue, think you've got under the skin of it, you know what's caused the issues, but you haven't actually got there. So that's something that certainly I've learned, and I think other members of the committee have. But I think it's very pleasing to note our new current position. Thanks, Alan.
Thanks. Alice, and then Janet.
Thank you. Just reflecting back, and I think I heard Leanne, you talk about this at some other update, I can't remember quite which forum it was, but how we avoid this being something that we've responded to, and the CQC have said they're impressed by our response, which is brilliant, but how we avoid an approach of us responding to an issue, dealing with that issue, and something else is popping up over here, and how we make sure that we are ahead of the game rather than reactive on other similar issues which may be there that we need to be conscious of.
Thank you, Alice. Yeah, very, very good question. So I think I talked in the presentation about the other 4 elements that we're looking at currently in terms of making sure we're not falling into the same trap with Mental Capacity Act, assessments, VTE, sepsis, pressure ulcers, etc. And we're doing some work around nutrition and hydration. Andrew McGovern is very heavily involved in developing what we have called a Perfect Ward app, and it's a kind of nationally known tool which provides very clear parameters for what you need to measure against each one of these practice elements. And our real steer is moving towards more of a peer review audit so that we can be very sure that we don't have any local bias, or you just forget to see what you see because you're in it all the time. It's like the hole in your wall that you need to plaster over, but you see it and you forget about it. So I think that's the direction of travel that we're taking, to make this more of a business as usual, but make it easier to do, but still give us the data and the information that we need. And I think as an organisation, with all our data up to this point, there's a lot of it, there's a lot of information, but actually seeing what really matters through all of that has sometimes been a challenge. So the reports that we need to generate need to be those that tell us exactly what the issue is, where it is, and what we need to do about it. So that's our next step. Does that answer your question, Alice?
It does, thank you. And I'm pleased to hear Perfect Ward's going to be useful in that, because I think I very much agree with that. Thank you.
Thank you.
I was going to Janet, but her hand has gone down. Do you still want to speak, Janet?
I've just put in the chat. My question was answered. Thank you, Chair.
Okay, sorry, didn't see that. Okay, Simon.
Thanks. So to say first, as we always need to, the CQC saw what they saw, and we have to accept that and take that on the chin. And I just want to say on behalf of us all, we do that, we accept it. I also want to thank everybody who's been involved. So it's important to acknowledge the contributions of the people who don't normally join us. So I'd particularly like today to thank Andrew, Gillian and Tina for all the work that they have been doing and continue to do on this. I want to just then finally make a point about, you rightly raised the conversation about metrics earlier on, and what do we look at and what do we not look at. And your question, Alice, I think is a pertinent one, because it invites us to think, as we start to redesign our IGR, maybe some of the things that we previously had been focusing on, we should be replacing with some of these type of metrics. So we start to think about, maybe the perfect ward should be at the heart of our performance reporting going forward, as a way of understanding for ourselves at board level how we're doing. It's not a definitive, I'm not making that as a definitive statement. I'm just making it as an observational statement to say, we focus a lot on output metrics, but looking at some of the really basic experiences of care that people have on our wards, I think we should certainly think about that going forward.
Okay, thank you very much, everybody. I think it's a hands up for what went wrong, followed by a pretty good report. My view about hospitals and CQCs is there are kind of 4 stages in it, really. And a few years ago, Kettering was to a large extent in stage 1, which was, it's not true. CQC said that, but it's not true. And then we got a bit to stage 2, which was, well, it is true, but it's really difficult to fix, so we probably can't manage it, which is where we were 2 or 3 years ago. And I think then you get to, well, it is true, and we can fix it, and we're going to fix it, which is kind of where you are now. And you're almost at stage 4, because stage 4 is, and we're going to keep it fixed. So I think in that sense, it's the story of Kettering is encapsulated to some extent in how we've moved through that on this particular issue. And Simon's absolutely right to start off with the CQC, what the CQC saw. I mean, they're right, it's simple as that. And I'm really delighted the way you've responded to it. And I'm really confident that not only will you fix it, have you fixed it, but it's going to stay fixed. A little bit of a flicker in the graphs towards the end, a bit dip down towards the numbers, but I'm confident you're on top of that. So thank you very much, everybody, for all you've done. And thank you, Leanne, for your leadership on that, and everybody else who's been involved. Thank you. Right. Thank you. Board assurance framework. Richard, I'd like you to go through this reasonably quickly, but it's also been on one cycle through all committees. So I'd just like to turn at least to some of the committee chairs, because I'm conscious of time, at least to some of the committee chairs and see what they think about the new board assurance framework. Richard.
Thanks, Alan. So I'll be quick in terms of introduction, because I think everybody has heard this in committees, both in the CPC around our group strategic initiative risks that we share with Northampton, and in the Kettering committees that have met this month. But briefly, having shared strategic initiatives and group priorities with Northampton has enabled us to create a shared pool of risks, which you see in the appendix there. But Kettering in its own right retains some risks. We've also redesigned the way this is presented, and that's been through committees in June for feedback on the presentation, and then committees again in July in terms of the content of those risks. So here it is, the new board assurance framework, which is now in component parts, and it's here for the board's approval. Thank you, Alan.
Thank you. Alice, CPC group risks. How did the committee think about this way of presentation and so on?
I think we were happy, Alan. I think it brought to the fore a number of things which I know we've touched upon, I think probably at the last board development meeting as well, around reminding us really as a board what some of those risk ratings actually mean and what we are signing up to, if you like. So I had a useful discussion on that. I think there was then quite a discussion around, were these the ranking we would expect, but actually, although that's important, really the discussion needs to focus around, as we all agreed, and Richard kindly reminded us, that's great, but it can become an academic exercise, and what we really need to focus on is whether the actions and the mitigations we've got in place for these are really doing what we think they should be doing. So support the overall direction, absolutely. Whilst we could argue till the cows come home about some of the minutiae, I absolutely support the direction of travel.
Okay, thank you. Other big risk areas are quality and money. Chris, quality, what did the quality committee think of this?
Well, we looked specifically at risks 1, 2, and 10, and we thought that the new layout and how it's reported was entirely positive, and we did not want to revert back to the old system at all. So it was a very positive move, so helpful.
Okay, look, thanks for that. That's 2 out of 5 or whatever. I'm not going to labour the point, unless anybody wants to tell me they don't like it from their particular committee point of view. Okay, thank you very much, guys. And there's more work to be done. It goes through cycles, and we've got to keep on top of it. And whilst it's not really much of a Kettering issue, I did slightly labour the point at Northampton yesterday, who had a bit of a habit of sort of looking at a 25 risk and kind of nodding sagely, and just to remind us that 25 is cataclysmic and likely to happen. So you don't really nod at a 25 risk, you go, and which bit are we shutting down now to fix this? I think we've made a lot of improvements here, but we do have to get quite into some of these higher risk areas, particularly in the estates territory. Anyway, so that will do for that board assurance. Any questions from members of the public? Richard, I don't think we do.
None received, Alan.
Thank you very much. Anybody got any other business? No, I don't think they do either. Well, we do actually, because this is Leanne's last public board meeting. She's hanging around, to be fair, till the middle of September, but we thought we'd better do the last board meeting stuff. And I was going to say something about elephants and graveyards, would have been entirely inappropriate, you know, because you started your career in Hampshire and you're going back to Hampshire, which will be nice. It's always one of the nicer counties in this country. But you've done a lot of clinical nursing. You've been in Kettering for 10 years, more than 10 years, and you've seen it through some not very good times and then some much better times. And looking around at the legacies, and it came up today in a couple of bits, was the practice development team that you've managed to develop and the way you've raised the standards of nursing across the piece. And all of that is the kind of thing, it's an embedded change. You know, it's not a kind of thing people, oh, well, Leanne left, so that kind of fell by the way. It's an embedded change, and that's the kind of thing that is a genuine legacy. And out of that, of course, it meant that your overseas nurses have all passed their exams. I mean, that's quite an achievement, and I don't know if that's been done in many other places. I mean, certainly in the other hospitals I've been close to, that's not been the case. So from through the rough and the smooth, finishing up, well, leaving aside the falls issue, pretty good. Big legacy development of improved nursing practice and practice development. Good senior staff. I've watched the empowerment of some of your matrons and some of the development for that. So I think you should look back on that with a great deal of pride. You brought a lot to the board. We're sorry to lose you, particularly because the rest of the team at Kettering are now, well, young and ambitious and exciting and enthusiastic, but you know, they're a little bit inexperienced, and your experience was very valuable. So it will be a significant loss to us. Anyway, we wish you well in your retirement, and we wish you enjoy the delights of Hampshire for a long, long time to come. Thank you very much for your work. Yeah.
Thank you, Alan. Thank you, everybody.
Okay, thank you very much, everybody. We're a little bit late, but I'm going to start the next one at 1:30 as we did. So if you could log out of this, it is a different one. It's MS Teams, so all the buttons are in different places when you come back. 1:30, please. Thank you very much, everybody. Thanks again.